Okay, so we're going to start our symposium for today. Greetings to everyone. Sasiaradolus, Shalom. My name is Datis. I'm the chair of today of the symposium. So to begin with, the idea for this symposium, it all came last year from a meeting of just 5 people. 5 people meeting up here, just in the room above here, in room 006. And we came with the idea of starting a small symposium of giving students a chance to be able to present the research work, to be able to gather more knowledge, and to be able to have an idea of what a medical symposium is. As future doctors, you will be attending different conferences as to get up to date. So in that meeting, Mrs. Aphrodite Pascoe and I, who were the co-founders of the Cyprus Medical Research Committee for Students, we decided to start this symposium last year. We held this event last year with a total of like 20 to 25 students only participating, but we didn't give up. We learned from last year's symposium how to make the symposium better. And the goal for today's symposium is continuous knowledge. As the great scholar of the 11th century, also a physician, Rambam, had said, no physician should say that I've learned enough. And he also said that the lifetime of no physician is enough to master his art. So, keeping those in mind, there is need for everyone to have continuous medical education, even in medical school. We're in medical school, we're learning 5 things, but we don't stop there. There's never enough to knowledge, according to Rambam. And following this philosophy, we start today's symposium with the slogan, tomorrow's doctors, today's dialogue. Last but not least, I would like to thank the members who were part of the social media committee in our symposium. This is Maria Kaplani and Mrs. Tala El Katsavi, who really did a great job. They are the real chairs here, because without them, no one would have known that this symposium is going to be here today. So I want you to give them another round of applause. Also, I would like to sincerely thank my colleague, Mrs. Aphrodite Pascoe. Without her, this symposium would have been impossible. Another round of applause for Mrs. Aphrodite, please. You really did a great job. You put from your time, from your personal time, to organize this symposium, and we're really thankful to this. Without you, nothing would have been possible here. Today wouldn't have been the day of the symposium without Aphrodite. And last but not least, I would like to dedicate this symposium in memoriam of Professor Costandino Marinos Peris, who recently departed 10 days ago from cancer after a long fight. He was one of the main professors of this medical school, one of the first professors of this medical school. Anything we have today, we owe to the work of Dr. Peris. And for this reason, I would like to dedicate this whole symposium to his memory. Thank you all.
I always get so nervous standing. So if I pass out, at least I have a room full of future doctors to, yeah, well, I hope so. But I won't keep you long because Datis already did a wonderful introduction for everyone. But I'd like to say good afternoon, kalispera, how we say in Greek, to my distinguished colleagues, to friends, family, professors that are here today. After last year's very small success, I'm thrilled to be able to welcome you all in our second annual Cyprus Medical Student Research Symposium. My name is Aphrodite Pascoe. I'm a fourth-year medical student at European University Cyprus, and I'm really, really honored to be chairman alongside Datis in this incredible event. Now, before we dive into today's program, which I know I'm sure all of you are very excited, I'd like to remind you of something very important, and that is everything that you see here today, the work, the blood, the sweat, the tears, many tears, is created by students. Students did everything here today. Every student in our team dedicated their own time out of their busy lives to come here today and organize this amazing event. This is why I feel that this symposium is a very big step for us students, because it shows the world, the small world of Cyprus, that we're not just future doctors, but also future researchers and future leaders. I want to especially thank our invited speakers and doctors, Dr. Zamboglu. He's not here, I think, no, but he will be coming later for his workshop. Their presence is a reminder that students learn from experts, and experts get inspired by the energy and vision of students. I invite all of you today, whether you are presenting or simply attending, to make the most out of this day. Ask questions and challenge ideas, and above all, enjoy the experience. With that, I declare the second annual Cyprus Medical Student Research Symposium officially open. Thank you all.
Right. Okay. Hello, everyone. Wow. So my name is Marinos. I'm a fifth-year medical student at the University of Lycia, and I'm currently based in Paphos, so I have to come all the way here, and it's amazing. So we would like to welcome everyone to the open discussion round for the symposium. This part of the program is designed to give everyone room to speak, speakers and guests alike as well. This chance to exchange perspectives, ask questions, and reflect together. We encourage you to participate actively and share your thoughts and engage in what we hope it's going to be a lively discussion. Starting off with the general surgery open discussion, we would like to welcome our group of students to the stage. This open discussion was guided by Dr. Polina Antonio. So we're ready to begin. Thank you. So. Yeah, so the members of the general surgery open discussion, we can. Yep.
It's just those three? I don't know.
Who sent it tonight? To Aphrodite? Yeah. That's it. Search it. You don't. I should have changed it. Ich. Around. Sorry, that's the wrong one. It's only my mother. So, it's only my part, not things. If it got said, should have the entire thing? No. So? Όχι όλο. 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 Yeah, if you can. If someone can do it. Παρακαλώ. Παρακαλώ. Μάλιστα. Ναι. Ναι, φυσικά πηγαίνω. Σε ένα λεπτό. Ευχαριστώ. Right.
So, hi everyone. So we're going to be doing a presentation. We were given a case about a 35-year-old male who presented with infective endocarditis affecting the tricuspid valve. We're going to be discussing 3 treatment options. And I should get this to you.
No way.
Okay. So as you said,
Wait.
it's not really good.
No. Let's go outside. Should work on.
Okay, as I said, 35-year-old patient who presented with infective endocarditis affecting the tricuspid valve. We were given 3 options of therapy: prolonged IV antibiotic therapy alone, conventional surgical intervention, or percutaneous debulking. So first I want to talk a little bit about prolonged IV antibiotic approach. So antibiotic therapy is the mainstay of treatment of infective endocarditis. Standard duration is about 4 to 6 weeks. However, in some cases where the infection is deeply embedded, it needs to be prolonged. And the purpose of this is just to completely eradicate the infection. The aim of prolonging the therapy, like I said, is to eradicate the bacteria completely, but also to monitor the situation more closely. There's some pros and cons of this. Complete eradication of the infection. It also prevents recurrence and other complications. It allows ongoing monitoring, as I said before, and it also avoids and delays surgery. However, we also need to consider that using the antibiotics for a prolonged period of time increases risk of toxicity and resistance, IV line complications, limited efficacy in severe cases, and patient burden because they have to be in hospital for a longer period of time. That being said, prolonged IV antibiotic therapy alone is the cornerstone of management for this condition and effectively sterilizes the infection in the majority of cases, avoids morbidity in invasive procedures, and addresses the underlying pathophysiology altogether. And that's why it should be considered to be the main treatment option.
So, good afternoon, everyone. I'll be discussing the conventional surgical intervention in tricuspid valve infective endocarditis. So, this refers to open heart surgery under cardiopulmonary bypass, giving direct access to the tricuspid valve. The goals are to eradicate infection, remove infected or necrotic tissue, and repair or replace the valve in order to restore the normal heart function. So why should we consider the surgery? First of all, for when medical therapy fails because of bacteremia or sepsis, despite all the antibiotic use, when there are large vegetations with recurrent septic pulmonary emboli, in cases of severe tricuspid regurgitation, and with fungal or prosthetic valve infection. So moving on to benefits and risks. Some benefits include the eradication of the infection, reduced embolic events, improved right ventricular function, and better long-term survival once the infection is cleared. Now, moving on to the risks. So, moving on to the risks, we have a perioperative mortality 5 to 10% of people, recurrence in IV drug users, and possible arrhythmia. So, in summary, conventional surgical intervention remains the treatment of choice for refractory or complicated tricuspid valve endocarditis, offering durable infection control and improved outcomes when performed promptly by a multidisciplinary team.
So AngioVac is also used because some patients have too high of a risk for open heart surgery, and it's minimally invasive. And what it does is it filters out to remove debris and bulk vegetation in large catheters, and like a veno-venous circuit. And after that, they also use esophageal echocardiography, or TE, and fluoroscopy to guide the procedure with precision. This reduces the bacterial load, which makes it effective, but it doesn't completely eliminate it. So the advantages are it's minimally invasive, there's no open surgery or bypass, useful for high-risk patients who can't undergo open heart surgery, and it allows patients to have bridge therapy, which is it's a step so that they can then have open heart surgery. It's good short term, but not the best for long-term treatment. And the disadvantages, it only removes partial parts of the vegetation, not all of it. It can worsen the tricuspid regurgitation. It's also expensive and requires expertise and lots of skills for vegetations to be removed, and no long-term data yet. It's a good option if you want something less invasive or non-surgical, but it's not the best if you want complete removal of the vegetations and plaque. Thank you.
Okay, so let's discuss.
Right, so presentation, guys. Gonna add some things to this presentation, so you can also add any questions or comments as I'm talking, okay? So here we have the case of a 35-year-old patient, IV drug user with tricuspid valve endocarditis, and you know tricuspid valve endocarditis is the most common cause. It's the most common type of endocarditis in IV drug users and in patients who have sepsis through a central line or through a peripheral line, because it's the first place where the bacteria can form vegetations, the tricuspid valve, through the veins, because it's through the venous system, okay? Here we have three therapeutic options. It's indeed a problem that we face in the clinics on what to choose for a patient who has infective endocarditis of tricuspid valve of any sort. You have to take into consideration different factors, and there are no certain guidelines for infective endocarditis that, okay, you have risk and get this therapy. Many times you have to have discussions between clinicians from different specialties to decide what treatment is the most appropriate. So in this case, for example, we have to take into consideration that you're talking about an IV drug user, that the possibility is that the patient will again use IV drugs. So due to this reason, if we don't have like a very severe case, you try to avoid surgery, conventional open heart surgery for tricuspid valve repair or replacement. Because if you replace, it's a heart surgery, the patient has to stay in the intensive care unit for 3 to 4 days at least, too much cost, too much burden for the patient. But again, if the patient's going to use IV drugs, it has even more risk, because if you have prosthetic valve, you increase the risk of having recurrence of endocarditis. So, like in such a case, if we don't have severe damage to the valve, we avoid surgery, okay? And this has to be done, evaluated through doing a PET scan. Now, you know everyone what a PET scan is. It's called a positron emission tomography, okay? So the PET scan is performed to see the condition of the valve. A transesophageal echo should also be performed 2 to 3 times before the sounding to see the prognosis of the patient, how the valve is going, and if the valve is severely damaged requiring surgery. Now we have the other method that Mr. Kevin just presented here with the AngioVac. Okay, AngioVac is a very novel method. Still, there are no guidelines saying, okay, you can do AngioVac and still undergoing trials, okay? There are countries, sectors that are doing AngioVac. Not in Cyprus, for example. We are not using AngioVac still in Cyprus. It's a good option if you have severe damage and you can clear up the vegetation from the wall. Next, we have the antibiotic, prolonged antibiotic therapy, which is usually the case which, like the hospitals here in Cyprus, choose this protocol of IV antibiotic therapy, but still it has its consequences, like because sometimes vegetations are created by biofilms, and you know biofilms are like the bacteria we have on our teeth, which everyone has, and biofilms around our teeth. And it cannot be eradicated using even the strongest antibiotic you can find in the market. So sometimes it's not logical to prolong antibiotic therapy more than 6 weeks. It has to be decided by an infectious diseases specialist. And it's always a question. So this open discussion we had today still is an open discussion forever, because there is no such answer for this patient. What should you should do a lot of follow-ups, a lot of examinations, and it's up to mostly the logic of the doctor. Here is where logic and thinking comes as well. Okay. If you have any questions, please. Yes, Mr. Snyder. Thank you. An extraordinary roundtable. Thank you so much.
Thank you very much.
So, thank you, everyone. This concludes our first open discussion session. In case anyone has any questions, you can still ask. Thank you
Also
to,
during break time, if you have questions.
yeah. Thank you to the attendees. Thank you to the students that worked on the group discussion. It was amazing. And yeah, so we're gonna move on with the conference. So, yeah, more presentations.
So, hello everyone. We would now like to welcome you all to the first block of our presentations, sessions of the symposium. This is a key part of our program, giving students the opportunity to present their research, share their findings, and engage in academic discussion. We would like to invite the first student presenter, Mrs. Ekaterina Bogdanu, to the stage.
Okay.
Good afternoon. I am Ekaterina Bogdanu, first year medical student at European University of Cyprus. So, let me ask you a question. Can something as simple as a tree resin help manage one of the world's most pressing health issues? We are talking about Mastic gum, which is an ancient resin that can help manage type 2 diabetes. Has anyone in this room heard about Mastic before today? Do you know what it is? Okay, only 3 people. Today we'll change that. Now, let's dissect the hype. In our presentation, we will talk about diabetes, how it is, what it is, and why it needs careful management. We will then move on to Mastic. We will talk about how this stuff works and how it can help manage type 2 diabetes. And I promise I will break it down for you to understand. And most importantly, we will look at the hard data and answer the question almost all of our patients will one day ask, should I try this as a complementary therapy? Please. Is there anyone in this room who has type 2 diabetes?
No one? Okay. Diabetes, let's not frame it as a textbook would. In simple words, it's just too much sugar in the blood. It has two types, type 1 diabetes and type 2. In type 1, the body doesn't make insulin, and in type 2, it makes insulin, but it can't use it well. And why does this matter? It's not just about high blood sugar, because long-term high blood sugar can damage the heart, the kidneys, the nerve, and the heart, and the eyes. So what if nature could lend us a helping hand? Here's where Mastic comes in. What is Mastic? Well, it's just gum. You know, the type of gum you chew for boarding class or you want to freshen your breath. Well, if it would be just that, it would be overrated. So it does more than just freshen your breath. I'll come back to this in a few slides. Mastic is a medicinal resin from the Pistacia lentiscus tree. So unique, it has a protected designation of origin like fine wine or cheese. The Romans used it for stomach wounds. The Ottomans valued it more than gold. And for centuries, people in the Mediterranean have chewed it for digestion and fresh breath. It has been used in medicine for more than 2,500 years. And why should we as scientists care? Well, scientists to me. Because it's a complex pharmacological resin that consists of almost 120 different compounds, including triterpenoids, like masticadenoic acid, flavonoids, essential oils, and phenolic acids. It is known for its pleasant aroma and antibacterial properties, and it has been traditionally used for digestion and wound healing. This isn't just a folk remedy. It's a pre-made chemical library from nature. And today, science is catching up with what traditional healers already knew. And why are we looking at a tree resin? Picture this, you are a diabetes patient, and while you're trying to manage this, you now also have to deal with nausea, low blood sugar, weight gain, and stress, thanks to your medication. It's a constant balancing act. And now patients are beginning to ask, is there a safer way to manage diabetes? Now, as doctors, isn't it our job to explore if there are any gentler therapies like Mastic that can help us find that balance? So going back to what we mentioned earlier, Mastic isn't just for freshening your breath or healing wounds. Studies have shown that it reduces inflammation and it helps as an antioxidant. It fights bacteria, it lowers cholesterol, and yes, it may even help balance your blood sugar. Talk about a multitasker, right? And how does this work? Let me break it down for you. Mastic helps your body respond better to insulin. It reduces oxidative stress, and it protects the cells from damage. It improves insulin sensitivity, it lowers blood sugar and cholesterol, and of course it supports liver function. It slows down how quickly carbs turn into sugar after a meal, and in short, it helps your body in multiple fronts. And you'll ask me, where's the human data? I hear you. Well, this isn't just a theory because a few years ago, Datis and other researchers and doctors took 179 patients with high cholesterol and randomized them into 4 groups. The first group was the group which received placebo every day for 8 weeks. Then the second group was the total Mastic group, which received 1 gram a day of Mastic. The third group was the polymer-free Mastic group, which received 1 gram a day of polymer-free Mastic. By the way, polymer-free Mastic is Mastic that has had its natural polymers removed. And the fourth group was the powder Mastic group, which received 2 grams a day of Mastic. Now, after just 8 weeks, the results were clear. In the total Mastic group, the patients saw their cholesterol and sugar glucose levels drop. Even better, overweight
and obese individuals had an even more pronounced effect. And most importantly, there were no side effects. And this is where I want to turn this all over to you, because this isn't just a presentation, it's a discussion that we all need to be a part of. Let's talk. If a patient sees this presentation, they will probably think, wow, natural, lower sugar, no side effects. I'm ditching my metformin. This is the uh-oh moment, because as future doctors, we need to have our answers ready. If Mastic helps control blood sugar, should people use it instead of medicine? What do you think? Yes.
Not to sound like a drug spreading doctor, I think definitely not. I think it should be used more in conjunction, which I think was also the goal of your presentation.
Yes, yes, exactly. Anyone else?
I don't think it can be used long term. Maybe for like short term. Mention to the medication maybe that would work.
Okay,
Long term, I think how it can help.
okay. Now let's see. Please change the slide. The answer is no, because Mastic is a complementary therapy. It's the supporting actor, it is not the lead. Replacing metformin with Mastic may be dangerous. Well, it probably is. That's why it is our duty to make that clear to our patients. Here's another question. Is this presentation nature vs medicine? Do you believe nature and science can work together in modern medicine? I'm just giving you some food for thought. What do you think?
So, because this is actually a very controversial topic now, even on social media, about homeopathic medicine. Personally, I have a friend who is a doctor and is specialized in homeopathic medicine. So the answer is homeopathic medicine and alternative medicine cannot replace modern medicine. It's just a form of preventive medicine. So you can prevent diseases from homeopathic, such as even your lifestyle is part of homeopathic medicine. So if, let's say, someone is using a lot of fats, a lot of sugar, overuse of alcohol, overuse of recreational drugs, and so forth, they can harm the health. So even that is part of preventing the disease. So using such kind of remedies like mastic, like walnut leaves, which now we use for cholesterol and so forth, they are not therapeutic, they are preventative. Okay, so
Okay. Please change the slide. It's time we stop seeing nature and medicine as opposites, because together they can offer a more complete solution. And do you know, please change the slide. Do you know any other natural products that have been successfully incorporated in modern medicine? Yes.
walnut leaves.
The most common is omega-3 fatty acid fish oil for cholesterol, which is actually part of guidelines now
Yes,
for
yes.
cholesterol monitoring.
Do you know anything else?
The same with the walnut leaves, which is the base for statins.
Okay.
All the statins we are using, rosuvastatin, simvastatin, they are all from walnut leaves. Walnut leaves have statins, natural. The same with estrogens. They are, let's say, we have phytoestrogens as a form of replacement therapies, and they are now guidelines for gynecologists.
You wanted to say something?
Aspirin.
Aspirin
is from the
Yes.
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 Do you know?
I think also puberty now is the first line treatment for multiple disciplinary.
Yes, yes, exactly. Please change the slide. Well, firstly, metformin. It's inspired from the French lilac. That's a very, very small tree. Then we have penicillin, which comes from a type of mold. And of course, we have paclitaxel. This is one of the most powerful chemo drugs, and it is isolated from the bark of the Pacific yew tree. Now, my point is, our job isn't to reject nature. Our job is to do what scientists who came before us did.
Firstly, we need to find the active compounds, validate them with RCTs, understand their mechanisms, and integrate them safely. That's not alternative medicine, that's the very essence of science progress. Now, please, thank you. Now, is my story complete? No. The literature has glaring gaps. Firstly, we need larger trials for more accurate results. Then there are zero data on type 1 diabetes patients and of course on young individuals, and we ought to change that. Now, some final takeaways. Thank you. Mastic is a promising compound that can support diabetes management, but it shouldn't replace conventional treatment. As we said, Mastic is a complementary therapy. It's the actor, it is not the lead. So, the next time you hear about Mastic, don't think of it as just gum. Here's a fun trick to remember it. M stands for mastic of Chios, A stands for anti-inflammatory, S for sugar balance, T for tummy friendly, I for inflammation fighter, and C for cholesterol helper. And then we have peer-reviewed studies from European journals that confirm the results. Thank you very much for your attention. Do you have any questions?
So thank you for your presentation, Mrs. Bogdanou. Thank you. So now we would like to invite the next student presenter, Mrs. Clemens Irene Nelly, to the stage.
Good afternoon, everyone. I'm Clemens Martinez, and today I'm going to present my project, which was undertaken at Swansea University in the cardiology labs under the supervision of Dr. Mark Bannister. And my project focused on exploring the mechanism of inhibition of prolonged perhexene incubation on cardiac ranitidine receptors, which are also known as RYR. So, first of all, does anyone know what an RYR receptor is? Okay, so ranitidine receptors are calcium-mediated calcium channels, which are embedded in the sarcoplasmic reticulum of cardiac muscle, but can also be found in smooth muscle and neuronal tissues. As we can see in over here in figure 1, under normal conditions, RYR releases calcium into the cell cytoplasm and triggers muscle contraction. However, in diseases like CPVT and heart failure, RYR becomes leaky and causes contractile dysfunctions, which can then lead to energy imbalances. RYR can therefore be a valuable therapeutic target in multiple diseases which have abnormal calcium signaling. In former research, pleiotropic drugs such as carvedilol was shown to alter RYR calcium signaling and to suppress SR calcium leaks. This has demonstrated that pleiotropic drugs like carvedilol have the potential to treat diseases that are linked to RYR dysfunction. An example is Alzheimer's, for example, which is a good area to explore in the future. And it so happens that perhexene is also a pleiotropic drug, and it is used in the treatment of angina and heart failure. And it mainly works by inhibiting CPT1, which is an enzyme that is responsible for catalyzing the transport of long-chain fatty acids into the mitochondria for beta oxidation. However, perhexene has also been shown to indirectly alter calcium handling by accumulating in the lipid bilayer and changing its physical properties. Previous experiments with perhexene have shown a time-dependent effect on the function of RYR channels. So by conducting experiments focusing on the equilibration and time-dependent effect, we can observe whether perhexidine can inhibit the calcium release currents. Our goal was to record the activity of perhexidine, incubated RYR, and compare it to a control to see if there was a statistically significant difference. So the single channel experiments were performed in the cup and block system, like this one right here. And it allowed us to study the electrophysiology of the channel, artificial environment, and involved several steps such as painting the bilayer, adding the protein so that the RYR could become incorporated into the lipid bilayer, perfusion, and then obviously the recording of the channel's activity. As shown in figure 2, the experiment was performed in a two-fluid chamber with a cis compartment, which represents the cytosolic domain, and then the trans compartment, which represents the lumen domain. And these two compartments were connected by a small hole where we painted the lipid bilayer and incorporated the channel. Okay, over here in figure 3, we can see a recording after perfusion where we have a double channel incorporation. And on the diagram, if you look here, the pink solid line, this represents the closed channel. And then if you look at the blue dotted line, which is O1, and the green dotted line, which is O2, that represents the open level of the first and the second channel. So this one will be the first channel, and this one the second channel. On image A, we have our control experiment, while on image B, it shows and demonstrates the effect of perhexidine incubated RYR. And in general, in experiments where we have multiple channel incorporations, we calculate the average PO. The average PO is the mean probability of the channel opening. So when we compare the average PO of the perhexidine incubated RYR to the average PO of our control, we can see that it is lower, with the average PO being 0.0126 for the control, perhexidine incubated one, and 0.0385 for the control. And this kind of like supports our initial hypotheses that perhexidine may have an inhibitory effect on the channel. However, we still need more successful repeats of the same experiment to ensure the drug's inhibitory effect on RYR, because this technique is very low yield. We need more kind of like results. And also it would be interesting to also explore kind of like the effect of different concentrations of perhexidine on the channel, as it has also been shown that at higher concentrations, perhexidine can have actually an active, like enhance the calcium leak instead of reducing it. Thank you for listening. And if you're interested in reading the full paper, you can scan the QR code. And if you have any questions, we'll sit down. Any questions? No? Okay.
Thank you for your presentation, Mrs. Martinez. We would like to invite the next student presenter, Mrs. Maria Gunnery, to the stage.
So, good morning again. My name is Maria Hunay, as I said before. I am a fifth-year medical student at the University of Nicosia. So today I'll be presenting my project. It's on melanoma treatment and genomic pathways. And it's a topic that reflects both my academic research as well as my clinical interests. So a few things about me. I have a very strong interest in ophthalmology and neurosurgery. I just obtained my BSc in biomedical sciences, and I am a member of CMEDRES Research. I'm a proud ambassador, and I'm very passionate about bridging scientific research and patient care. Okay, so today I'll guide you through 5 key aspects. So what is melanoma and why it's clinically unique, how it's diagnosed and how it's classified, the management framework from surgery to radiotherapy, targeted therapies and immunotherapy, and finally, how personalization and genomic pathways are shaping our future. So melanoma accounts for only about 1.7% of global skin cancer diagnosis, and it causes the majority of skin cancer-related deaths. So it's a very lethal disease. Its aggressiveness lies in its high mutation rate, in particularly involving genes such as RAF, NF1, and RAS. Mortality has dropped nearly 30% in the last decade, thanks to immunotherapy, and incidence continues to rise globally. So this paradox highlights how biological complexity and environmental exposure, especially UV radiation, continue to challenge prevention and management. So diagnosis lies on the ABCDE and EFG rules. And I know it sounds silly, but it actually is acronyms. So it's assessing asymmetry, border irregularities, color variations, dynamics, and whether a lesion is elevated, firm, or growing. But beyond clinical observation, there are technologies such as dermoscopy and RCT or OCT that actually help diagnosis. Melanoma isn't one disease. Oh, and I have some pictures for reference. So this is the colposcopy, this is the OCT, and I have a table about melanoma and what is benign and what is melanoma. And as you can all see, there's no differences. So it's the same thing. It's very hard to diagnose. That's why it's a very interesting case. So melanoma isn't one disease. It involves several subtypes. So superficial spreading is the most common. Nodular, it's the most lethal and the more aggressive. Lentiginal malignant is usually in exposed skin of the elderly, so sun exposed skin of the elderly. And acral lentiginous is also in darker skin populations. It's very potent. Each subtype carries unique genetic mutations. So KIT and NRAS mutations are more, KIT and NRAS mutations lie more in lentiginal malignant. And these differences, as you can all tell, they differentiate pharmacodynamics. So, yeah, okay. So for surgical management, it's the cornerstone of melanoma treatments. For localized tumors, it's the best choice because you can actually excise the entire tumor and the entire lesion. It's curative in most cases, but for more delicate areas, MOHS, which is micrographic surgery, it helps more with preserving healthy tissue and being able to preserve as much as healthy cells as we can. Sentinel lymph node biopsy is critical for staging and for being able to distinguish metastasis. It's worth noting that even with advanced cases of disease, metastasectomy can prolong survival. So radiotherapy and chemotherapy. Historically, melanoma has been considered radio-resistant, but there are modern approaches like stereotactic radiosurgery and gamma knife that remain gold standards, given the fact that it's so genetically prolonged and weird that it's one of the treatments that can allow for full curation of the disease. Chemotherapy includes dacarbazine, dacarbazine and platinum-based drugs, temozolomide, but it still plays a limited role because it's mainly for palliative reasons. However, temozolomide has an ability to cross the blood-brain barrier, which offers a very valuable treatment offer for melanoma. So moving on to targeted therapies. This is some sort of graph that I included in my thesis. It's kind of representative of how chemotherapy works in response rates. So as you can see, temozolomide is one of the more effective drugs that we can give. Okay, so for targeted therapies, genomic pathways, there are two major signaling cascades that dominate. It's the MAPK-RAS-RAF pathway, and there are several mutations like the RAF mutation, as I mentioned before, and also the P13AKT, which is altered in nearly half of melanomas. So as you can understand, it's very important. So resistance often develops within months. So drugs like vemurafenib and dabrafenib, they target RAF mutations, so it's easier to treat and cure. Another emerging focus is TRPM channels, specifically TRPM1. And these channels could represent the next wave of targeted innovations. So immunotherapy revolution. So it's a true game changer, immunotherapy. Checkpoint inhibitors like ipilimumab, so CTLA-4 inhibitors. Anyone that is interested in oncology will probably know CTLA-4 inhibitors. So they have a 5-year survival of over 35 to 34%, even in advanced cases. There's also growing evidence that combining immunotherapy with radiation, particularly SRS radiation, is a very promising field. So this is radioimmunotherapy. So moving on to personalization and future directions. So TIL therapy, the advantage of TIL therapy for melanoma is that it works after PD-1 failure. And the challenge is that there's limited persistence. So vaccines also exist, but even though it's personalized, the tumor heterogeneity and the genetic background of melanoma does not actually help with diagnosis and cure. So biomarkers, again, very important. They predict response to prognosis. However, validation is needed for specific melanoma types. Okay. So future directions, challenges. Despite extraordinary progress, resistance and tumor heterogeneity remain challenges. So again, TIL therapy, it works after PD-1 inhibitor failure. So the most responses in metastatic melanoma. The process is to extract T cells and expand ex vivo, so you reinfuse them. The challenges, limited tumor-specific T cells, poor resistance, and the research right now says optimizing expansion protocols using in brain metastasis. So neoantigen is another one, and it offers high specificity and long-term protection. There are two vaccines that are available. It's NeoVax and mRNA vaccines, and they show strong T cell responses. And the challenges remain tumor heterogeneity and optimizing antigeneity as well. So, yeah. So the last slide, basically biomarkers that I referred to before. We have blood-based DNA methylation and gut microbiome. So the blood-based is LDH, so the bad cholesterol. It's useful, but not specific, and there's no research data that actually tells us that this is an actual thing. DNA methylation, again, MGMT is actually hypermethylation. Yeah, there is some research on this, but not a lot as well. It's promising for monitoring. And gut microbiome, it can provide diversity that's linked to immune response. So the challenges for biomarkers are basically that there's variability across studies. So we don't have enough research yet for the specific disease to actually provide something. Yeah. So thank you very much. If you have any questions, I'll be happy to answer.
So thank you for your presentation, Mrs. Gunnery. We would like to invite the next student presenter, Mrs. Nancy Al-Jamal, to the stage.
Hi everyone, my name is Nancy and I'm in the first year of medicine. I'm going to present the shaken baby syndrome. So what is the shaken baby syndrome? It is a serious form of abuse head trauma and it occurs usually when the baby is under of 2 years old. It usually occurs when a parent or caregivers takes a baby violently out of danger or frustrated because the baby will not stop crying. Injuries that characterizes are intraocular and intracranial hemorrhages with no evidence of external trauma. In extreme cases, may result in death. Shaken injuries are not caused by bouncing a baby on your knee, bicycling with your baby, force of a furniture, or sudden stops in a car. According to the World Organization, it is estimated that 40 million children are abused annually worldwide. In Cyprus, we don't have the answer of how many babies are affected by this syndrome. Violent shaking has its most serious in the baby's head. Babies have very weak neck muscles that cannot fully support their proportional head. Severe shaking causes the baby's brain to move violently back and forth, against their skulls, whiplash-like mechanism, and this can cause the bleeding in the brain or behind the eyes. The acceleration is the least harmful. Is the result of moving object hits stationary head. Acceleration, which is the most severe brain stem injuries, and is the result of moving head straight stationary object. The shaking causes subdural hematoma, subarachnoid hemorrhage, and brain damage. More specifically, is a result from a lack of oxygen. Also, we have brain cell damage, or specifically brain swelling at the lack of blood and oxygen may result renal hemorrhages and fractures in ribs, collarbone, arms and legs. The symptoms are not smiling, lethargic, vomiting, extreme irritability, feeding problems. Also, we have dilated pupils, inability to follow movement with their eyes, voice, hair, inability to lift their head, and breathing difficulties. The diagnosis is difficult for several reasons. Firstly, healthcare doesn't always get the truth about whether or not shaking was involved. On the other hand, babies can't tell the truth or what happened. Many symptoms such as vomiting are common and also in other conditions. And last but not least, a healthcare provider will use visual cues and tests. These tests may include, firstly, history, how it happened, social history, and previous medical history. Whole body examination, external injuries, optic fundus exam for retinal hemorrhages. Also, CT scan with candidate injuries, MRI scan, X-rays, and blood tests. Differential diagnosis, accidental head injury, infectious causes such as meningitis, neoplastic conditions, seizures, and metabolic disorders. This syndrome can be treated within the specialties of intensive care, neurosurgery, neurology, ophthalmology, orthopedics, radiology, and pediatrics. For milder cases, the baby may need medicine to reduce the brain swelling. In more severe cases, the baby may need surgery for brain to reduce the brain swelling and stop bleeding. Babies may develop, firstly, cerebral palsy, intellectual disability, vision loss, and epilepsy. Death is usually caused by the intracranial pressure from cerebral edema. This syndrome is 100% preventable, but the caregivers should understand the dangers of shaking the baby, not shake the baby out of frustrated or injured, and lastly, ways to elevate their stress. Relevant authorities. The legal implication of syndrome involve charity welfare and criminal investigations. Thank you for your time. Any question?
Excellent presentation. I just wanted to, not rather than a question, but actually just a discussion point, because I really, really like this topic that you've chosen. I think it's really important, you stated it in your first slide as well, that a lot of people mistake that it's some sort of like shaken baby syndrome is some sort of disease or something that can happen by accident, but it's really not. It is abuse. Like, you can never do this to a child by accident, as Nancy put in her first slides. You can't get it from the child bouncing in the car seat or accidentally falling. Like this, although it's considered a syndrome of after what happens, it is abuse. So I think it's really important that as physicians, especially if you're going into pediatrics or emergency medicine, to be able to differentiate that a lot, because you immediately have to get police involved. It kind of goes beyond a physician's care point. Excellent. Thank you so much.
Very interesting presentation. Thank you, Mrs. Jamal. We would like to invite the next student presenter, Mrs. Meryl Mukarker, to the stage.
Hello, my name is Marinos, and today I'll be presenting my narrative literature review on schizophrenia and the role of estrogen. Okay, so this paper will explore the neuroprotective role of estrogen in schizophrenia's pathophysiology and management. Schizophrenia can be considered a life-threatening condition. This led to multiple clinical trials aimed to find the precise etiology behind its manifestations. Today, we will lightly touch on the main hypotheses of schizophrenia while focusing on the estrogen hypothesis and utilizing it for future management plans. Multiple studies have shown that the onset of schizophrenia varies between the two sexes. Here we have in figure 1, we can see that the continuous line is the male schizophrenia patients and the dotted one is the female patients. And we can see that males experience symptoms around 20 to 25 years old, while females have two peaks. The first one is around 25 to 30 years old, and the second one is around 40 to 50, which is also around when menopause occurs, and the estrogen levels drop significantly. And this discovery has led scientists to explore further that like estrogen's role in delaying or relieving schizophrenia symptoms. Okay. Schizophrenia's pathophysiology remains a complex and widely undiscovered area, regardless of the extensive research, as multiple areas of the brain are affected, as well as multiple neurotransmitters, hormones, and enzymes. The most influential hypothesis as of right now is the dopamine one. The dopamine is the most abundant neurotransmitter in the brain. Therefore, it's very crucial that all the dopaminergic pathways function normally. And however, it's been discovered in schizophrenia that there is an excess of dopamine in the mesolimbic pathway, which can cause positive symptoms such as auditory and visual hallucinations and delusions, while there is low levels of dopamine in the mesocortical pathway, which can cause the cognitive and negative symptoms. Another way that dopamine might cause negative symptoms is through abnormal reward processing, but this area of research is still developing and needs a very extensive research. Schizophrenia also involves the dysregulation of two other important, can we go back, please? Sorry. Two other important neurotransmitters, glutamate and GABA. The glutamate hypothesis focuses mainly on the NMDA receptor hypofunction, and this dysfunction usually leads to abnormal synaptic plasticity and cognitive impairment. At the same time, the GABA system, which normally balances excitatory activity, is also impaired, and this can cause deficits in working memory and attention. Some researchers even propose that schizophrenia stems from immunoexcitotoxicity rather than neurotransmitter imbalance, suggesting that treatment should target this root cause instead, as well. Okay, and now to the main question of this paper, which is how does estrogen play a role in schizophrenia, and how can we utilize this role in managing it? Estrogen's neuroprotective effects are thought to occur through a mnemonic mechanism that activates estrogen receptors alpha and beta, which promote neuroprotective growth factors and inhibit pro-inflammatory molecules. A negative correlation was found between estrogen levels and the severity of symptoms in schizophrenia, as we can see in this figure that shows the symptoms of schizophrenia across the menstrual cycle. It has been observed that during phases of low estrogen, patients seem to have more severe symptoms and worse psychotic episodes, and there has been an appearance of new and more severe symptoms right after menopause. There's also a strong genetic link between estrogen and schizophrenia, as variations in the estrogen receptor alpha gene, particularly the CC homozygote, are more common in patients and linked to more severe symptoms and poor treatment response, while T allele carriers show an earlier onset of symptoms. Furthermore, studies suggest that estrogen mainly influences schizophrenia symptoms through dopamine regulation, as it can increase sensitivity of D2 and D3 receptors in the mesolimbic pathway, which subsequently helps reduce the psychotic symptoms. And now to the second part of this presentation, which is the management part. The dopamine hypothesis has long been the main target for drugs in schizophrenia, but we have noticed that most patients usually stabilize after like a little while or show little improvement. And these limitations have led to the development of atypical antipsychotics and novel adjunct therapies such as serotonin receptor antagonists and estrogen augmentation, especially in hypoestrogenic women. As of right now, the current guidelines for the treatment of schizophrenia includes typical and atypical antipsychotics, as well as non-pharmacological interventions. Okay, and here we have a figure that shows the hotspots in the brain for schizophrenia, as well as the distribution of estrogen receptors in the brain. And we can see that there is quite the overlap, which further strengthens the correlation between these two. Current and past researchers have been investigating the potential use of estrogen as treatment for schizophrenia. One way that estrogen can affect the treatment strategies is through its inhibitory effects on the isozyme CYP1A2, which metabolizes antipsychotics such as clozapine and olanzapine, and therefore directly increasing their plasma levels. And multiple clinical trials have conveyed very significant results, presenting the possibility for the usage of estrogen or selective estrogen receptor modulators, SERMs, as adjunctive treatment for schizophrenia. For example, a recent clinical trial involving 200 premenopausal women with schizophrenia confirms further that adding a 200 microgram estradiol patch as an adjunct to their antipsychotic treatment has a significant impact on the patient's positive and negative syndrome scale PANSS. We will see a figure about that in the next slide. However, due to concerns relating to long-term effects of estrogen supplementation, such as increased cancer risk, breast and ovarian cancer risk, as well as feminization in men, the off-label usage of SERMs is considered superior and relatively safer. A study has shown promising results in relieving cognitive symptoms, which typical and atypical antipsychotics has failed to do. The administration of adjunctive raloxifene at 120 milligrams daily in both men and women improved verbal memory, attention, and perceptual motor processing speed. On the other hand, some argue that adjunctive raloxifene not only failed to benefit severe cases, but also worsened patient outcomes, which raises the question of whether raloxifene's effects on cognition and symptoms are coincidental or truly beneficial. Genetic associations and the mentioned clinical trials, including ESR1 polymorphisms, further suggest a role for estrogen in disease susceptibility and treatment response. However, the evidence base is limited by small female-focused trials, heterogeneity in dosing protocols, and long-term safety concerns. Thus, while estrogen provides a plausible unifying mechanism bridging multiple neurotransmitter hypotheses, larger sex-inclusive studies are required to establish its validity. Here we have a forest plot that compares the effect of adjunctive estradiol with placebo on the PANSS scale, the blue line being the placebo group and the red and green line being the groups receiving the adjunctive estradiol. And we can see that the people receiving the estradiol got lower results on the PANSS score, which means lesser symptoms were observed. And here we have a table comparing the three different treatment regimens in schizophrenia. The first one being just antipsychotics, whether typical or atypical, and they have shown reductions in positive symptoms and a modest relief in negative symptoms. Some of the limitations of this regimen are the extrapyramidal side effects of typical antipsychotics and the metabolic side effects of atypical antipsychotics. The second regimen is the antipsychotics plus direct estrogen supplementation, which we mentioned earlier that has shown great improvements in clinical trials while increasing cancer and thromboembolic events. The last regimen includes antipsychotics and SERMs, whose benefits and limitations we have discussed earlier. To conclude, the growing evidence of estrogens and neuroprotective roles suggests that hormone-based therapies could advance schizophrenia treatment, particularly as adjuncts to traditional antipsychotics. And regarding future developments, firstly, we would recommend genetic screening as it may allow personalized estrogen-based treatments for schizophrenia by identifying the ESR1 and 2 polymorphisms. Secondly, various studies have shown that men and women respond very differently to different treatment regimens, which calls for intensive research to develop sex-specific treatment guidelines in order to reach optimal results in all sex and age groups, as well as regulating the dosage, sample size, and trial duration in order to get more consistent results. And finally, we would recommend further exploring hormonal imbalance in schizophrenia, as it would provide us with a more comprehensive image of its pathophysiology. And that's a QR code for anyone who wants to read my paper. Thank you so much. Anyone has questions, you can go. Okay.
Thank you for your presentation,
Thank you.
Mrs. McCarver. We would like to invite the final student presenter, Mrs. Lara Noor Jandi, to the stage.
Good afternoon. My name is Lara Jandi, and today I'm going to be presenting my narrative literature review about the diagnosis of post-traumatic stress disorder, PTSD, and the use of neurochemicals and biomarkers. So the significance of this research is that early and accurate detection of PTSD is critical, and there have been a lot of doubts and suspicions about the current diagnostic methods, mainly claiming inaccuracy and subjectivity. Now, the pathophysiology of PTSD is not yet fully understood. However, clinical research shows associations between abnormalities in key brain areas and neurochemical dysfunctions. So in this paper, we aim to use these rapidly evolving findings on pathophysiology to guide our research into alternative diagnostic methods. So first, let me just explain to you a bit about the current diagnosis. So this is a brief overview of the DSM-5 diagnostic criteria, which is the basis for all diagnosis of PTSD currently. It has criterion A, which is the trauma exposure. This is very important. We'll get to it shortly. And it has 4 symptom groups, which are intrusion symptoms, avoidance symptoms, negative cognition, and hyperarousal. And it has the other criteria, which are exclusion criteria and duration of symptoms. So the way this is used is through the PCL5 and the CAPS5, which are the 2 current methods. These are both based on the DSM-5 criteria. The PCL5 is used as more of a screening method, as it's done solely on how the patient reports their symptoms, while the CAPS5 is the current gold standard and is assessed by a clinician. Now, more importantly, the limitations of the current diagnosis. So the first thing is ambiguity. The credibility of the current diagnosis is highly doubted due to the fact that diagnosis is mainly based on how a patient reports their symptoms. Although a clinician does finalize a diagnosis, it is still all based on what the patient says. And studies have, for example, found higher symptom severity when using CAPS-5 than PCL5, which may be due to personal biases or a lack of understanding of the scaling. So this raises concerns about the accuracy of diagnosis and how this can lead to over or under diagnosis of PTSD. And another thing is the criterion A debate. So this is a debate that arose after PTSD was added to the DSM-3 in 1980, and it addresses the definition of a traumatic event. So in the current DSM-5 criteria, the circumstances that are considered traumatic are defined as actual or threatened death, serious injury or accident, or sexual violence. And it is argued that this criteria lacks inclusivity as it doesn't include other exceptionally stressful circumstances which could lead to trauma, such as severe financial difficulty. So as a result of this, studies have begun to explore how diagnostic method can be advanced to limit this exclusivity, then accuracy, and make it more objective. So this brings us to our research question for today, which is how can biomarkers be used to improve the diagnostic accuracy of PTSD, and what are the potential advantages and disadvantages of clinically implementing them? So we're going to assess this by looking into studies on the physiologic changes that occur in PTSD and see if these could potentially be used as biomarkers to identify it in a less subjective way. So let's begin by looking into some biomarkers. So first, neurochemicals. We have norepinephrine, and studies have shown that studies have found increased urinary and central levels of norepinephrine in people with PTSD, and this occurs due to decreased levels of the norepinephrine transporter in the brainstem. And the study also suggests an association between norepinephrine levels and specific hyperarousal symptoms of PTSD. Additionally, people with PTSD have been shown to have decreased expression of the alpha-2 adrenergic receptors. So while these findings do show potential as biomarkers for PTSD, a limitation is that these studies focused mainly on men, so it lacks heterogenic results. Moving on to serotonin, individuals with PTSD exhibit reduced paroxetine binding. Paroxetine is an SSRI. So this indicates lower serotonin transporter levels in PTSD, and this also contributes to arousal and avoidance symptoms of PTSD. We also have GABA. A study done by the University of Leiden measured the gamma plasma levels of veterans with a 10-year history of trauma and found significantly lower plasma GABA levels in those with PTSD. And this finding actually aligns with a lot of previous research which was done on GABA. A limitation is, once again, that this was focused on men. However, a study did recently come out which focused on men and women. So this shows very promising potential as a biomarker, just more research is needed. And the last neurochemical we're going to look at is glutamate. A study conducted by Rosso reported elevated glutamate levels in the right hippocampus of PTSD patients, which is linked with re-experiencing symptoms of PTSD. So now we'll take a look at some non-neurochemical biomarkers. First, the inflammatory marker. There exists a significant comorbidity between PTSD and inflammation, so this is a highly researched topic. Studies have found increased levels of pro-inflammatory cytokines in people with PTSD, as well as increased levels of CRP, and the increased CRP concentrations were actually linked to worsened PTSD symptoms. Additionally, a study by Bonomi discovered that individuals with PTSD displayed neuroimmune suppression, which was linked to greater severity of anhedonic symptoms. So this means that immune markers can not only be used to diagnose PTSD, but also to narrow down which subtype of PTSD the patient has. So this is very beneficial. We also have neuroimaging modalities such as single photon emission CT, which offers valuable information on cerebral blood flow and perfusion patterns in people with PTSD. And we have resting state functional connectivity, which has shown unique connectivity patterns in PTSD. An advantage of this method is that it also aids in identifying the subtype, as it can differentiate those with and without dissociative symptoms. And lastly, we have functional MRI, which has shown increased activity in the amygdala and decreased activity in the prefrontal cortex in those with PTSD. Now, the last biomarker we're going to be looking at is epigenetics, more importantly, microRNA. Studies have found significant differences in microRNA expression in those with and without PTSD. So now that we've understood the potential biomarkers that can be used for diagnosis, let's look at the clinical implications and the limitations of how we can put these in a real life scenario. So firstly, these biomarkers have strong potential to provide objective and quantifiable measures of PTSD, which is very beneficial to tackle the limitations in the current diagnosis. And another key advantage is the role in personalized medicine. As mentioned, some of these can help us with identifying PTSD subtypes, which can not only help with diagnosis, but also with management of each patient. However, despite these benefits, integrating them has a lot of challenges. Firstly, standardizing biomarker assessment protocols, ensuring reproducibility across different labs, and addressing ethical concerns, which we'll talk about in more detail shortly. So the challenges and limitations of these studies. One key issue is variability. So biomarker levels can fluctuate from person to person based on things like comorbid psychiatric disorders, medication use, lifestyle factors. For example, inflammatory markers are elevated not only in PTSD, but also in depression. So this makes it difficult to use as a biomarker specifically for PTSD. And I think this is the most important limitation, as this applies to most of the biomarkers that we discussed today. Another major limitation is heterogeneity. PTSD is a very complex disorder, which with multiple different symptom clusters, and not all individuals exhibit the same neurobiological changes. So this means that a single biomarker would probably not be sufficient to be used for diagnosis, and rather a panel of biomarkers would need to be implemented, which is not so easy to integrate in the real world. And finally, the ethical and legal considerations, of course, must be taken into account. The use of biomarkers PTSD raises concerns about an increase in stigmatization and potential misuse in, for example, social and occupational settings. And it leads to the risk of over-reliance, which would lead to false positives or unnecessary medical interventions. This is just a quick table summarizing neurochemical and non-neurochemical biomarkers, what they tell us, and their limitations. And finally, future directions for this research. I think most importantly would be to focus on multimodal biomarker models that would integrate neurochemicals, imaging modalities, and immune markers to improve diagnostic accuracy and tackle the heterogeneity limitation that we discussed earlier. Additionally, advances in machine learning and artificial intelligence can actually be very helpful in facilitating this process. For example, through the use of pattern recognition. So machine learning can produce algorithms to analyze vast data sets to identify patterns or combinations of biomarker results in those with PTSD versus in those without, as well as predictive modeling. So AI can build models that predict the likelihood of PTSD occurring, which would help with early detection as well as prognosis. And finally, in order to make this all come to life, it's important to increase affordability and accessibility. Thank you very much. Please feel free to questions.
In the start, you said that there were some studies that only had males.
Yes.
Was there a specific reason with this? Is it because PTSD affects men more than women, or was it just a study specific?
It's study specific. A lot of studies focus on veterans and military
Right.
personnel,
Makes
so
sense.
yeah.
Thank
But studies are evolving, so hopefully.
And another comment, very nice presentation. You made a narrative review on this topic, but for everyone who's here, I'm just saying that there's a topic that can be meta-analyzed, okay, for some subgroups, for example. And it's, I think, a nice research topic for everyone who likes to work on it. I believe that you should consider making a meta-analysis at some point on this to be able to have more fair statistical figures, because you know, the meta-analysis is on the top of the pyramid. So if we can make a meta-analysis on this topic, you can actually prove that these biomarkers are like tangible for use, okay?
Thank you very much.
So thank you for your presentation, Mrs. Jondi. So this concludes the first block of the oral presentations. We would like to thank all of our students, presenters, for the time and the effort they put into their work and for their courage to share their findings with us today. Please see us later for the second block.
We have a break now, so please be back at 3:30.
We will see for
Thank you.
the systematic review what
Hey, I presented bottom view.
Yep,
I made some last minute changes in the presentation.
that's fine.
Can I just send you an email?
Yeah, of course. Do you have it on a USB?
I have it on my computer.
Okay, send it as an email. Do you have the same address email?
Yeah, I'll send it.
You can send it there.
Like,
Yeah, of course.
Yeah, the workshop with those then he's not here, so I think I'm just gonna show my stuff.
Πού θα έρχεται, μπορεί να έρθει κατευθείαν. Τι διατύπωση είναι.
Whatever. If he does, he does.
Τι θες να μου πεις, είναι στο άλλο folder.
No, I'm gonna, no.
No?
No, I'm gonna show my stuff for the cervical vaginal.
Okay.
That's him.
Sure, yeah.
The same, huh?
Perfect. Let me check.
Be from Marinos.
Yep,
Thank you.
got it.
Thanks.
Do you know your number? Maybe number. It's cars.
Cars, yeah, that's the one.
The previous presentation was this one?
They look the same at first.
Oh, okay. Okay, I found you. This one, correct?
This is the good one, yeah.
Cool. Okay.
Okay?
Yeah, all done. Thank you so much. So. Your number 13, is there a schedule here? I'll show you.
Yes.
If I were to do second or something, I would rather do it with thankfully. The more interested in it, that's why if you have a work, I love it more. No, yeah. So try to do like it's the or not. I mean, yeah. Look at that. Yeah, it's like I don't know what to put forward. I don't have.
Okay.
Then my, I go somewhere. I don't know what I mean, like, we don't play it, yeah, like, they think it's not, that's for me, you know, for me, no, it's just there's. Okay, I'll switch that. I can't have to run away, but synchronize, what happened, yeah. Yes, yes. Yeah, it's like, yeah, double tap your arms.
Was in the same position. Like the same. I'm so sorry. Very lost in
Yes. She's trying to network.
I decorated my whole house for Halloween. It's not. Yeah, I see it. Then enough for it. It pisses me off. Get this. Ahora poniendo. Okay, I'm going to look too much. I love Christmas. Yes. But I would decorate so early. Now it's Halloween, now spooky season. But it pisses me off that it's so hot instead. Like, please hide it. They don't have to feel free to prove it. Okay. So I'll see that. If I can go off. Get the. And then, so that's all none. So we'll see. And there's always something to do. My life is. Oh, Mastic. Oh, Mastic, right. Oh. He said, I'll figure out what we came out and said I didn't earn the person. I just want to make sure you can. Oh, she may have lost me. Oh,
do research, whereas, okay, let's say in other countries like the United States, like Israel, like Canada, it's much more easier to do an original work. In Europe, it's more tight. You need a lot of bioethical approvals in order to be able to do an original research. But we come to our second research now, okay? Review studies. What are review studies? Review studies are basically when you take already published literature, which is scattered, because every day tons of literature is being published in different journals, okay, from different countries, from different institutions. And at some point, you need to be able to collect all those facts, because how science works is sometimes you can even find contradictory results, okay? So let's say let's say one paper says, let's say that high levels of one biomarker, let's say, is associated with, let's say, risk of developing prostate cancer. Another paper might tell you exactly the opposite, that the results were not statistically significant, or even tell you the opposite, that lower levels of a biomarker, let's say, is associated with a higher risk of prostate cancer. Get the idea what I'm talking about? So when I go on PubMed and I, let's say, put this biomarker and prostate cancer, I come up across many studies which are contradictory. So what's the final result? Is it correlated? Is it not correlated? High levels, low levels? So for this reason, you as students can take the initiative to research whether the published records show a statistically significant result, or even give a description of what the results are forming a review paper. There are two types of main reviews that we're gonna talk about today, not the usual, like, we're gonna talk about the usual kinds of reviews, not the like specific types of reviews, like scoping reviews, like state-of-the-art reviews, which are like more difficult. And hopefully next year, in our next symposium, I will present more complicated research topics on review papers. But today we're going to see two types of research: a narrative review and a systematic review. How many of you have done a narrative review here? Narrative review. A lot of you. How many of you have done a systematic review? Okay, as if you have done. So as you can see, a narrative review is usually more convenient to do, because a narrative review, what is a narrative review? You just take the literature, you read it, and when do we do narrative reviews? We do narrative review on the topic if the topic is very wide, okay, so it covers a lot of different ideas, which you cannot combine it into one research question, saying, okay, this is my research question that I want to answer, so I can systematically review the research question. Or it's when you have, how do you say, you've got a topic where the literature is so scattered, or you've got studies which are still in vitro. You know, in vitro, it's a Latin word. Vitro means glass. In vitro means that it's done in the lab, because lab utilities are made of glass, right? So in vitro studies, or they are in vivo animal studies. So they like on rabbits, on hamsters, on mice. If you have such studies, you cannot do a systematic review. A systematic review is discouraged. So there you will do a narrative review. You will find the topics, make a map. A very good way to do a narrative review, guys, is to make a diagram, okay? To make a diagram. Put your ideas on the diagram, find the findings, and draw arrows connecting the ideas to see how one topic is connected to the other, how the one paper is connected to the other. And then, through this diagram, you can start kind of explain the topic, summarizing your results in tables, in figures, okay, and making a narrative review. Whoever wants can send an email here, okay, to signmetres@science.gmail.com. I will answer you to send you some of my personal narrative reviews so you can have an idea if you haven't done a narrative review to the moment, and if any of you wants to do a narrative review and has a topic in mind, please don't hesitate, you can contact me and I can guide you with the very few hours I have, because I'm very busy, but I will try my best to guide you, okay? Now we come to the systematic review, which my colleague Aphrodite is gonna now explain the systematic review. So, yeah, Aphrodite, to the podium for what the systematic review is.
This one.
This one should just to say systematic review is systematic. You have to follow a certain structure, okay? Certain methodology, which will be explained.
I'm no expert, but I would consider that the research that I've done, most of it is systematic reviews. I'm currently in 4. And then this was my first ever one that I did with my team. We still haven't published it, obviously, but I kind of wrote down a doc explaining everything for them. So this was last minute. This is not polished to show you guys. So please just take this with a grain of salt. But I kind of just explain what a systematic review is. And it's a way of finding and summarizing all the research on a specific topic in a structured and organized way. So instead of just looking at a few studies, for example, a narrative would most likely look at a few studies. A systematic review gathers every single literature piece out there to the capacity that the researchers can, obviously. Checks if they are high quality, checks if they are relevant to the topic, and combines all their findings to answer a specific research question. So if you can just, sorry, scroll all the way down to here. So this is where the first step is creating a clear research question. So say you wake up one day and you really like a specific topic, you really want to talk about it, so you want to write a systematic review about it. The first step would be to create a clear research question. And specifically for systematic reviews, we use the PICO framework. Does anyone know what that is? Yeah, okay, so it involves 4 things: population, intervention/exposure, comparison, and outcome. So once you have a question in mind or a topic that you're interested in, you formulate that question based off of the PICO framework. So for my first systematic review, which was the association with cancer and the cervicovaginal microbiome, I wanted to see women that were diagnosed with cervical cancer or at risk of cervical cancer. For example, they had like a HPV infection. And then the intervention/exposure was the cervicovaginal microbiome composition, so the different bacteria that's inside the cervicovaginal microbiome. And then the comparison would be obviously healthy, non-altered microbiomes. And then the outcome would be to see if it progresses into cancer. So basically, just by using these 4 things, I already established a solid research question, and I know exactly what I'm looking for when I'm looking through my literature. And then now that we have a PICO framework, we can frame our research question. So in this case, it's what is the association between the cervicovaginal microbiome composition, so the composition of the different bacteria, and the persistence of HPV infection, immune modulation, and its progression to cervical cancer. So after we've done that, which I consider one of the hardest steps in making a systematic review, is because you really have to start with a really good research question, because if you don't have a really good solid research question, you don't know what you're looking for. So in my personal opinion, whoever is interested in doing this should focus on the PICO really, really well. Then secondly is to develop a protocol. So systematic reviews are very rigorous, is that they follow very strict guidelines and protocols. And the good thing is that these are freely available for you guys on the internet. So I use the Prospero protocol. So this is, I think it was from the University of Greenwich.
Prospero.
Prospero,
I think it's University of Greenwich, but basically most good solid.
York.
Yes, York. So they all mostly use Prospero. So you can just go on the Prospero website, download their protocol, and it has like a really good template that explains everything for you. And this is where you start to develop. So you just go through the questions one by one in your protocol, and you just ask ChatGPT to explain if you don't understand, or just Google it. I use ChatGPT a lot for when I was starting off with my systematic reviews, just because I really didn't understand what the protocol of Prospero entailed. So I would just upload it into ChatGPT and be like, hey, can you explain this as if I'm 5 years old and don't understand anything? And it just really helped kind of, yeah. And also, I think a really good way is just to brain dump everything into just a doc. And this is what I've done here. I've just brain dumped everything. And this really helps if you're working with a team as well. So all systematic reviews must have a developed protocol. It contains a comprehensive description of our systematic review, including the rationale. So rationale is, why are we doing this? Like, you can't just wake up one day and be like, hey, I'm going to do this. You have to have a reason behind this. Is it because the literature out there, there's gaps in the literature? Is it because you have a really concrete hypothesis and you really believe that this could be the case? Is it because there's so many good studies out there that prove this? You have to have a reason. I think it's wrong to go into a systematic review just thinking, oh, I like this, so I'm going to do this. You actually have to have a reason. So keep that in mind. Next, you have to register your review on Prospero. So after you've downloaded the Prospero template, which I will show you mine after. Once you've registered it, you've written everything, it takes a little bit of time. I think there's like 38 questions on Prospero.
40, 58, I'm not sure.
Anyways,
you have to.
a ridiculous amount. After you've gone through that ridiculous amount of questions, and they basically ask you for your whole life story, you can register it to Prospero. Then you just click like the website, and they'll explain everything for you. It's very straightforward. You just upload your draft. You make sure that everyone that's on your research team accepts the registration, and that they consent basically to being a part of the paper. And then after like a few days or max like a few weeks, they'll accept your registration. And that's when you can move on to the actual process of gathering data. So if you just scroll down, yeah. So I don't know why I put this at 4, because I usually do the search strategy in conjunction to Prospero, but like the search strategy basically involves like, how are you going to look for studies? Do you want primary studies? Well, all systematic reviews are primary studies, but you can also kind of, am I going to use gray literature? Am I going to look at the references of those primary studies? So by developing a search strategy and also seeing like, what studies am I looking for? Am I looking for studies where it's women that have had an altered microbiome, but also have a control group? Am I looking at studies that have a specific demographic of people? Am I looking for studies that are in a specific, I don't know, geographical area? So this all involves your search strategy. So you need to figure out a search strategy using your PICO framework. So as I said, my PICO framework involved my population, which was women that were at risk of having cervical cancer, like for example, a previous HPV infection with a HPV strain that can cause cervical cancer. So when I'm creating my search strategy, I'm including that in it. So that's my demographic. So obviously I'm going to go on PubMed or whatever, and I'm going to look at studies that have women, not men, because you know, they don't have uteruses or cervixes. So that makes sense, right? But a good search strategy minimizes bias and makes our papers strong and supported. And this is really important, because if you have a very wide search strategy, so say you have a research question and you have a very wide like range of people that you want to include, if you're not careful, you can get bias, because if there's too many people and it's not too specific to your research question, you start getting bias and all sorts of bias in your actual data. So you have to be very careful with how narrow or how wide you want your search strategy to be. Yeah. So this, after you've done all that, which is quite repetitive and boring and really tiring, that I consider the most tiring part of research, you can actually go into the fun part, which is actually screening your studies and selecting them. So I highly, highly recommend you guys. I did not know about this software before I started using it for my systematic review now. It's called Rayan, so RAYYAN. It's free. It
honestly, I cannot recommend it enough. You can upload your references directly into it. It'll help you put little tags if you want to reject or accept your articles. It has AI features which removes duplicate articles for you. It is literally incredible. Like, it has cut down how much time it takes me to go through studies so fast. So please use that. I didn't use it in this one, so this is why if you look really closely, you'll see my tears on the pages. It's because I didn't use Rayan. But so when you're screening and selecting your studies, if you use Rayan or you don't use Rayan, I know some people are very old school, they like to print everything out. It really depends on you. Some people like to use Excel sheets. It really is up to you. Once you find like your perfect way of screening, you can go in and what I do is I ask ChatGPT, right, to give me like my search criteria. So I send it my protocol. I'm like, hey, I need you to give me some search criteria for PubMed, for example, or whatever Scopus, like whatever website you're going to be using to like search for your literature. And then I just copy paste the mesh terms that ChatGPT creates. And I copy paste them into PubMed or Scopus or whatever. And then all the articles that come out, you can, if you go on the top right, you can download them as an RSV file. And if you download them, you can upload them into Rayan. So you don't have to go in one by one and export the PDFs for your Excel sheet, or if you're going to print it or whatever. Like, this is why I love Rayan. But yeah, so as you're screening studies, there's 2 steps for screening. I think, yeah, phase 1 and phase 2. So phase 1 is title and abstract screening. So this is exactly what it says. You read the title and you read the abstract. Is it relevant to your topic? Is it relevant to your PICO question? If it is, good, you can pass it on to phase 2. If it's not, you can reject it and it won't go into phase 2. Then phase 2 is full text screening. Again, the bane of my existence. I have had so many mental breakdowns full text screening. So this is, you just have to read every single little line in the review or in the study, sorry. You just have to read every single little word. So this is probably the most time consuming, but it is also the most valuable because this is where you learn so much. So it's probably the most important on a personal level, I would say. Because you have to go in and read everything. And if you have, like, this study has like 200 accepted papers. So you can imagine I have to go through with my team and read every single paper, and there's 200 of them. So that's thousands of pages. So you have to know what you're getting yourself into when you're deciding this. Next we have data extraction. So after you've gone through phase 1 and phase 2, where you have all of your accepted articles. So we were lucky with Datis, we're doing myeloma research. We only had 10. So 10 papers, that's all it was. After we screened everything, after the team accepted rejected articles, we had 10 articles left, like 10 primary studies left. So after you have all of your studies, your approved studies, you can go in and start extracting your data. So the data is what you want for your outcome. So for example, if I have a study that states, I don't know, they tested 200 women that had previous exposure to HPV, for example, like a dangerous HPV strain, like 18 or 19. And they had like a follow-up period of whatever years, and they're going to see if they ended up developing cervical cancer, okay? So after I do that, I check what I want to extract from that. So I want to extract the number of women that ended up getting cervical cancer, and that's relevant, okay? And then there's a lot of other things that is relevant for data extraction, like title, authors, year of publication. Another important one that I do is funding, because, you know, if you have big pharma funding a study, that could be biased. So that's important. What else? Oh yeah, the Prisma flow diagram. I'm not gonna lie, it's a little bit, I wouldn't say redundant, but it's basically the same thing in just a different way. And also Rayan does the Prisma flow chart automatically for you. So that's how. Yes. So that's great. Oh yeah, so I just have some examples here. So the following data will be extracted: study details, authors, year, country, and funding, study design and methodology, because we want primary studies. So participant demographics, age, geographical region, reproductive status. These are important because, for example, geographical region, right? Some women have more like genetic links towards cervical cancer. Some geographical regions have less access to preventative measures or cancer screening. So that would automatically skew the data because they're at an increased risk. Microbiome analysis method. This is important. Like, how do the scientists in their research analyze the microbiome? Because obviously it can give different results. And then obviously outcome measured, HPV persistence, clearance, cervical cancer progression. This could even involve, like, they get diagnosed and then they die. That could still be considered an outcome. Immune modulation, microbiome composition. Okay, this is all boring. Statistical data, I'm not even going to talk about that. Yeah, so then after you've extracted all the data, you have to do your bias. So depending on what type of study you have, there's different bias too, like Cochrane or Robbins. So depending on which one you have, you'll learn this in EUC. Litras teaches this course. Let's not summon him, but basically, like, depending on what study you have, you also have to use like a specific bias tool. So you basically, these tools, like, they have like a table and you get a point, like your study gets a point or a star for each like bias assessment. So if they, like, for example, exposure, when the exposure was like calculated or whatever, when it was taken in, blah, blah, blah. So honestly, I would need a whole other hour to explain like the bias assessment tools. So I'm not going to bore you on this one. And then that's all I've written, because after that is the writing stage, and I haven't gotten to that stage yet. So the writing stage is considered like the easy one, because it's now you just have to write. You have to write what you found, and yeah, that's it from my end.
So just
That's all I could give you guys.
complete a little bit. It's very detailed description by Aphrodite. Description. So just to complete a bit with the quality assessment. Basically, we usually if we've got cohort studies or case control studies as the main studies inside our systematic review, okay? We're gonna use the Newcastle Ottawa scale. Basically the name of two cities, one in Britain and one in country. Newcastle Ottawa scale, which actually has some columns, okay? And you give a mark according to what you believe, and you always need two reviewers. So as Aphrodite also said, you always need a simple systematic review. You cannot do a systematic review. Whoever tells me that he's done a systematic review only on his own, he's biased, and his publication is retarded.
Yeah.
It's retarded, because you cannot do a systematic review on your own, because everyone has bias. No one even talks, okay? Everyone has bias. The reviewer's bias is very, 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 very important. Okay? And given the fact that the reviewer's bias is very important, you always need two reviewers at least to do a systematic review, so you can compare. And if you have any discrepancy or any form of disagreement between you, you need a better review. So at least the systematic review paper needs to have 3 authors listed. Otherwise, the journal should retract, because it's a retarded paper. It makes no sense to do a systematic review with one author. And last but not least is the part with doing the meta-analysis, which is very difficult. Okay? I personally have done 2 meta-analyses, and I had trauma stress disorder after doing the meta-analysis, because it's very difficult. You're gonna get so confused trying to do a meta-analysis, but for those who are interested, for those who want to take the initiative, because some people are
Crazy.
challenges like me, okay?
Crazy.
Yeah, crazy. And sometimes you take challenges more than my capacities. So if someone has a similar personality, can take a meta-analysis. But anyway, just to briefly say what a meta-analysis is. A meta-analysis is when you've got some studies which have a statistical marker. Okay, let's say, you know what an odds ratio is, everyone here? Odds ratio, everyone? Okay, so let's say the studies give an outcome of an odds ratio that gives a result, okay? So you take the odds ratios from each study and you calculate the pooled odds ratio. You calculate the p-value for the pooled odds ratio. You do a plot which shows the odds ratio with its 95% or 90% confidence interval, okay, which is called the forest plot. You describe the results and you find the pooled odds ratio, which is as if you've done a new study in the meta-analysis. It's like taking all the patients and taking them under the umbrella of one study, okay? So you've got like, let's say 10 studies on the research we're doing.
We're not doing a meta-analysis.
You're not
We're not doing a
no, because anyway, there we have heterogeneity.
Yeah, yeah.
So it's possible. If you've got, let's say, 10 studies which are homogeneous is actually a Greek word, homogeneous, which means they are similar, okay, in the way that they are conducted, in the conditions they were conducted, okay. The only difference should be the number of patients. If you have homogeneous studies, a meta-analysis basically gives you a pooled result, taking all the studies as if they were one study, okay? It's like combining all the studies, and you are doing a study in the virtual world, okay, somehow, from different under the umbrella of a meta-analysis. Just as if it's a whole new study, and it's, as I said before, during your presentations, a meta-analysis is at the hierarchy of medical research papers. Why? Why is that at the top of the pyramid? It's because a meta-analysis combines different studies. You may have studies with thousands of patients. So the meta-analysis is actually, let's say, giving results on tens of thousands of patients. So it's a big statistical sample, which kind of can show the population, at least let's say in a village, okay? A village can be considered as a population where we can apply to a bigger population, right? That's the mind of the statistician. So the meta-analysis is very, very, very important. If there is no meta-analysis on the topic, you can never do guidelines, never, okay? We need meta-analysis to be able to put guidelines. So let's say I found this biomarker, okay, and this biomarker is showing results that it can help us, let's say, see prognosis of the cancer or diagnose a cancer or something. If I want to put this into guidelines, let's say to take it to the European Society of Oncology, ESMO, and make it integrated into the European Society of Oncology's guidelines, I need to have at least one meta-analysis to be able to confirm that what I'm saying is correct. Don't have much more to say. I don't want to get you guys confused. If any of you has any questions, you can.
This is
send
sorry,
here.
just literally for 2 seconds. This is my most recent Prospero article. So you can sorry, Prospero protocol. So you can literally download the template as it is and then just fill it in. So for example, I'm currently doing research with Dr. Psaran, Dr. Menelao. Some of you here might know her from EUC. So we just have the review title, the condition or domain being studied. So in this case, it would be reproductive health, the rationale. So this is, like I said before, is super important. So we basically wrote why we're doing this. And as you guys know, AI is a huge, like, hot topic right now in medicine and in research in general. So we kind of wanted to put that like on the forefront of answering this question, is that artificial intelligence can potentially take our jobs and take over the world, blah, 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 blah. So that was kind of the rationale for our review. And then the objectives would be what we're aiming to address, like what kind of questions we're aiming to address. And this is also the PICO framework that I told you guys from before. I don't know what's happening here. Why does it do that? Okay, well, okay, so the eligibility criteria is like what I told you guys before, the PICO, so population. What's included, what's excluded? For interventions or exposures, what's included, what's excluded? This goes on and on and on. And then the outcomes that we're going to be analyzing. Like I told you guys before, for my other systematic review, it was
Yeah. Ah, yes, sorry. Okay, so for my other systematic review that I showed you guys before, it was like the assessment of cancer. And then for here, it would be like, since we're doing a study for reproductive health, just to see how AI is grading embryos in IVF, it would be like implantation rates or pregnancy rates, how many embryos that AI thought can be successfully implanted, how many of them were successfully implanted versus the ones that just casual human embryologists said that can be successfully implanted. Is that it? Oh. Yeah, so here, like I said before, they want your whole life story, where you're from, social security number. They basically want everything. Conflict of interest is very important as well. You have to state that you don't have any conflict of interest. For example, you're not getting paid by some institution to do this research, because this, unfortunately, research is very expensive. A lot of researchers, doctors, they rely on funding from pharmaceutical companies to be able to do their research. So you do have to declare conflict of interest. It doesn't mean that your paper is bad or there's anything wrong with it. You just have to declare it. There's nothing wrong with declaring conflicts of interest. The biggest mistake you can make is not declaring it. That's literally it. If you declare it, no one can tell you anything. Like, you could get funding from whoever you want and no one can say anything because you've declared it. So that automatically makes you non-biased. So that's also very important. Yeah, so as you can see, funding source has no institutions, whatever, peer review. What else? Is that it?
And even just to add, like, now you're seeing a lot of nonsense coming down as research, and they are politically funded.
Yeah,
especially like by certain populist parties, which are actually paying.
that's also a really bad,
Yeah, and
unfortunate thing that happens. You have to make sure that what you're
so you always
reading is
have to be
accurate.
careful, because many times there are PEPs who are paying for the research. So always, even if you don't have a conflict of interest, which you don't, most probably you're not going to be funded by a political party, or not going to be funded by a big tech, like a giant or something. But always read the conflicts of interest in the paper you are using, because many times, especially now, we're seeing a lot of papers in the past 2 months. 2 nonsense papers came out from the United States that were funded by the populist.
But even if you're not using these papers, like, even if you're just doing it for yourself, say you have a project for school, or you're just reading up on something for your own personal interest, go in and quickly, before you read the paper, look at the conflict of interest. It takes 2 seconds and it will really change your perspective of what you're reading in front of you. Okay. And then the last thing that I'm going to show you guys is, remember when I was talking about data extraction, like the final stage before you start writing? I use, this is for Datis and I research on myeloid. I have just a plain old Excel table, and this is how I do my data extraction. It's very time consuming. It takes me around 2 hours, 3 hours for each paper, and I have 10 of them. So it can be a little bit time consuming, but again, Rayanne helps speed things up. I swear I'm not sponsored by them. I just love them. But as you can see, I just go through and write the title of the paper, I can't even see, the number of authors, the years that the data was collected. This is very important because there's some research that takes a really long time to get published, right? So you need to make sure that what you are studying now is relevant from when the time was collected, so when that data was collected. So it's very important to include that, because older things could be skewed by things like the pandemic, for example, skewed so many things. So you need to be careful with that. The journal, obviously, because some journals could be like what's that word? Aggressive journals? No. Some journals, yeah, the impact factor, like some journals can be like damaging because they'll try to they have a they basically try to get money to publish things. So you need to make sure that you check the journals, check the impact factor, which is free to access on the internet. So you don't have to pay to get that information. Study design, obviously, country, and then these are all basically
actual like data from studies. And then all the way here, I have like my bias, how I do my bias. So I say what tool I'm using, and then these are the little stars that I put for each. Yes, I used this one, but and yeah, and then just comments and stuff. So this is like the most basic data extraction you can get. It doesn't get like, if you want it more basic, you can do it on pen and paper, but that's literally it. You just open up an Excel file and you start extracting. So I think that's it.
And for the research question, sometimes there's a phenomenon that in the past years, in older times, people would start doing the research and then like in the middle of the find in PubMed as they're like reading all the sources that actually systematic review published 2-3 years ago exists on the topic. So we're basically doing work that's not workable. Now, thankfully, we've got ChatGPT. Yeah, we are not sponsored by AI Big Text. We're just trying to show you that AI here can actually be of material. We just use ChatGPT, DeepSeek, Google Gemini, and any kind of AI search engine tool. And right, does a systematic review on this topic of this. The artificial intelligence algorithms will go and search through the whole internet to see if an article exists. So you can just like, in the beginning, look, I'm not going to this topic, so I'm going to think of a new question. So you can actually be sure that the research question you formulated is the correct one. Okay. Any questions? No? Thank you all for your attention.
Okay, 10 minutes and we start our block 2 oral presentation.
Yep.
4:30.
4:30.
Sorry.
Are you next?
No, I'm not this one.
Do you know your?
Yeah, I'll see on the first page.
No, it's-
This one, this one,
Let's make it quick.
this one.
This one.
Yes.
Sure. What do we do?
Thank you. Might be. I'm trying to remember the sentence.
Sorry?
Trying to remember useful markers. Thank you.
That's it?
Yeah, that's
Okay,
it.
perfect. Thank you.
Yeah, no, you need to break it down. I thought, okay, so.
I know, it's Please say something else about something.
I don't, I'll do it right now.
Yeah, I was going to the finally. Whatever. Yeah. Okay, that's cool. So we have it. Okay, I just like it ready. Yeah, sure. Yeah, sorry, if you want to say. So, just having that speech, just like say. Like it's something that's. Yeah. So basically, that's a lot of first. There's not enough research also on all of others. So. The best way to do it is your
Yeah, that's true. But even if you're, I consider they look like it.
Yeah, Yeah, so basically all the behavior, let's say, for the picture and within the conversation. Mira, por favor, ya sí puedo.
Yeah. Με τη μήκωση. Αφροδίτη με το 20. Βάζεις αυτό εδώ, το μάμπο το 20.
Τώρα.
Ναι.
So, guys, welcome back again. We now like to welcome you all to look at our presentations from the presentation, and thank you all for attending. We would like to invite the first student presenter, Mrs. Amanda Shaw.
Get a pointer.
Yeah. Perfect. Hello, everyone. Thank you for joining me today. My name is Amanda Shaw. I'm a third-year medical student at the University of California. I have a special interest in neurology, so today we're going to be talking about serum neurofilament light chain, whether or not it can reliably be used to predict relapse in relapsing remitting multiple sclerosis. Now that's a lot of words that I just threw at you, so I'm going to use some abbreviations today. I'm going to refer to serum neurofilament light chain as SNFL, or just neurofilament. And then when I'm talking about MS, relapse and remitting MS, I'm probably just going to say MS or multiple sclerosis. Oh, there we go. Okay. So let's start broad. What is MS? MS is a chronic inflammatory immune-mediated disease in which our body attacks the myelin around our nerve fibers. This leads to demyelination or axonal degeneration in the central nervous system. According to the MS International Federation, MS is most prevalent in countries of northern latitudes. So we're talking Germany, Canada, Sweden, Norway. See this represented in the red countries here. This is known as the latitude gradient of MS presentation. Multiple sclerosis presents 4 different ways clinically. We have primary progressive, secondary progressive, clinically isolated, and relapsing remitting. Of these 4, relapsing remitting is the most common, accounting for 85% of the MS diagnoses, which is why we will be talking about it today. So if we're going to talk about relapsing, we might as well define what a relapse is. A relapse is new or worsening neurological symptoms lasting at least 24 hours with or without complete recovery. It has to be without a fever or signs of infection and must point to a demyelinating event. So even with this robust definition of what a relapse is, determining between a true relapse, a pseudo relapse, and another critical event in clinic can be actually quite difficult, which is why we have a problem here. So currently, MS patients undergo routine MRI screenings. We can see here on the slides, they do brain and cervical spine MRIs, but they also do thoracic MRIs depending on symptom presentation. MRIs are the gold standard in identifying new or active lesions, which is what these arrows are pointing out, and those lesions are the hallmark of ongoing inflammation in the body. So the problem we have is that we know MRIs are very expensive, they're research intensive, for patients, they're scary, they're time consuming, and for healthcare, they pose quite a big burden, especially with, in Canada, one of those countries of the highest prevalence, like I said before, we have, it is mandatory that we do MRIs once every year for patients who are stable, and then patients who are with new symptoms or new treatment, they do anywhere from 6 to 12 months. Obviously, individually, these things change, but that is generally to give you the idea of the strain on the healthcare system. So the question is there a simpler, more cost-effective, less invasive way to track disease? And that is where we get into serum neurofilament light chain. So these are just some of the articles that were published recently, but to be honest with you, between 2024 and 2025, there's been a lot of research done with SNFL, and they have all shown that SNFL is the most highly researched biomarker in MS right now. So what is it? It's a structural protein that we find in our axonal cytoskeleton. So when we have axonal degeneration, this structural protein gets broken down and is put into our cerebrospinal fluid and also in our blood. And using very high sensitivity assays, we are able to pull it out of the serum and trap it, which has been so incredibly great. So supporting evidence for SNFL, we know that SNFL levels rise when patients with MS are having a relapse, as opposed to those who are not. As well, these SNFL levels, they correspond really well with MRI presentation, with clinical presentation, and with EDSS scores, or clinical disability scores that we give at every single follow-up. We know that, like I said, it's non-invasive, it's cheap, it's repeatable. And actually, this last point is very new. A study published September 2nd, 2025 outlines that patients that present with higher SNFL levels are more likely to experience a relapse within the next year compared to those who do not. And we see this backed by other research of those experiencing relapses generally have higher baseline SNFLs than those who are pretty steady and stable. So the challenging evidence, of course, there has to be some. First one is timing. So SNFL levels don't always rise before symptom presentation. Sometimes they rise afterwards, and usually it's up to a couple weeks afterwards. So it kind of shows more of a reflective piece than a predictive piece. As well, SNFL is not specific to MS. We do see it in all diseases that have neuroaxonal degeneration. So we can see it in TBIs, we can see it in strokes, we can see it in Alzheimer's. And finally, because we have these confounding factors, we also actually see it as we age. These levels increase. So accounting for those confounding factors and deciding what those normal, abnormal ranges are has been difficult so far. Okay, so the current clinical role right now is that doctors use SNFL and neurofilament levels as an adjunct biomarker to complement MRI findings and clinical presentation. It should be noted that not every physician actually uses neurofilament levels. The MS community is very split on this. Some people think that it's not worth it. Some people think that it's a good adjunct. I think most people like to use it when the clinical picture is not necessarily clear, or they just want additional confirmation of a true relapse. A lot of doctors also use it to determine frequency of MRIs. And currently right now, it is also being used in research to see whether or not certain treatment protocols are working. So this is just a general summary of what we've talked about so far: strengths versus limitations. Non-invasive, repeatable, specific marker, follows MRIs and clinical relapse. Limitations are that it's not specific. It has more of a predictive power and, a more reflective power, not predictive power. And we do need to find adjustments for those confounders. So the key unanswered questions that we have now are: can SNFL levels reliably predict relapse prior to MRI presentation or clinical presentation? If so, at what levels do we escalate treatment, and how do we adjust for those confounding factors? Take-home points that I want to leave you guys with: SNFL does differentiate a relapse and no relapse with good specificity. It is used very well with the MRI and the clinical presentation. It does have a reflective power, but that predictive power just isn't there yet. But it is very highly researched right now, and I feel like this is going to make its way into MS care very soon. So finally, I will leave you with the question: do you think serum neurofilament light chain should be used in relapse and remitting multiple sclerosis care? Those are the references, and thank you guys so much.
Thank you, Mrs. Shaw. That was an excellent presentation. So now we would like to invite the second student presenter, Mrs. Rim Tala, to the stage.
Hi, everyone. Very happy today to be presenting to you the surgical management of gallstones in the United States. So a little bit about myself. I'm from North Carolina, and this summer I was in general surgery back in my home state. So this is something that we did see quite a lot. So I thought that it was really important to make a presentation about. So first of all, we need to understand the epidemiology of the disease. Is this a disease that we're frequently seeing? Or is it something that is very rare to see? So for us in the US, this affects 10 to 15% of adults, which equates roughly to 20 to 25 million Americans, which is quite a significant amount. It accounts for roughly 1.8 million ambulatory visits a year, but it's very important to note that this is most likely an underestimate, as a lot of these elective surgeries are done outpatient. There is way more than 750,000 colostomies performed annually. For us, the month that I was in general surgery with my surgeon, we performed about 9 cholecystectomies, but there were about 4 other surgeons on the floor. So that just kind of gives you an idea of it. It's something that you very typically see in the clinic. You'll see patients presenting with abdominal pain, and it is something that you schedule, which I'll talk about later. So the main risk factors for gallstones disease are the 4 F's, but they're not limited to. So the first one is female. You're going to see that a lot of these go back to hormones. So female have higher level of estrogen when they're pregnant, undertaking oral contraceptive pills. This increases your bad cholesterol, which in turn decreases your gallbladder contraction. The next one is obesity, which once again increases your estrogen levels, which leads to higher bad cholesterol and a decreased gallbladder movement. Next, we have 40. So 40 doesn't necessarily mean that the day that you turn 40, you're going to be more prone to getting gallstones disease. It just means that, like a lot of other diseases, as you get older, you're more prone to it. And in this case, the enzyme which digests cholesterol, which is cholesterol 7A hydroxylase, is decreased in production in the body. So if it's decreased in production, well, this means that obviously you're going to have more cholesterol in your body. You're going to have a buildup, which is increasing blood cholesterol, and that will, in turn, once again, decrease your gallbladder contractions. And then the last 4F is fertile. Pregnancy increases your progesterone levels, and progesterone is a muscle contractant. So that will relax your gallbladder and lead to bowel-stasis, which is you just have an accumulation of bowel in your gallbladder, and that will then lead to the formation of stones and calcification of it. So the clinical spectrum of gallstones, we have divided into 2 main things: the symptomatic presentation and then the asymptomatic presentation. So an asymptomatic gallstones would be like me right now in front of you. I am not presenting any symptoms. I don't have any tenderness, but I could very much have a gallbladder full of stones. But I wouldn't know, and you wouldn't know either, because upon examination, no pain. I would have some normal labs results, nothing indicating anything. And in 70 to 80% of the cases, it remains silent throughout the whole life. I don't have flare-up or an incident leading me to needing a cholecystectomy. Now, the surgical aspect comes in a symptomatic presentation, because obviously if my patient isn't undergoing any pain, well, I'm not going to need to remove their gallbladder. So the symptomatic presentation, you have 3 main ones, which you will quite commonly see at the hospital: a biliary colic, which is when you're going to have a stone in the cystic duct, but that will move. It's not stuck in the cystic duct. When we have a stone which is stuck in the cystic duct, that is going to have a persistent obstruction. It's going to lead to an inflammation, fever. That is acute cholecystitis, which is the most common case that you will see, or that we've seen at least. And then the next one is a cholelithiasis, which is when you have a stone in the common bowel duct. So it is dislodged and it is stuck there. That's going to lead to elevated jaundice levels and your LFTs as well. Some complications of delayed management is empyema, which I'll show you guys photos later in the presentation, perforation, gangrene, and sepsis. So the diagnostic approach in the United States and how does that happen? The first thing that we do, it's the first line imaging, is an ultrasound. It's easy to do, it's not expensive, and basically every hospital has it. It can also be done at bedside, depending on which patient we have. That can detect gallstones, wall thickening, and pericholecystic fluid. So I have a photo right there of what an ultrasound looks like in an acute cholecystitis. So we can see the pouch is filled with stones. It's very easy to see, and anyone can detect that there's stones in there. Lab tests. So this is optional if my patient is asymptomatic, because like I just mentioned before, an asymptomatic patient can have normal lab results. So there's no big point in making them take a lot of exams and subjecting them to this and then extra costs as well if I know that those results are going to be just like any other patient. If I have a symptomatic patient, the 4 main tests that I'll be doing is checking LFT levels, lipase amylase, my white blood count, and then my CRP, my symptom inflammation. Further imaging, so this is only in the cases where we're going to have, like we mentioned before, stones in the common bile duct. So there's 2 main imaging techniques, which is MRCP and ERCP. So MRCP is going to be done through an MRI, and ERCP is endoscopically. I would do an MRCP if I suspect a common bile stone, but I'm not 100% sure of my diagnostic. Sometimes we're able to see them in ultrasounds. You can kind of see it at the top, but it's not always evident. So if I'm suspecting one, I would do an MRCP, which essentially looks like this. So we can see our stone right there in the common bile duct very easily. If my patient doesn't have a stone, then obviously I don't see anything. MRCP is only a diagnostic tool. So once I've detected stones, well, there's nothing that I can do with an MRCP anymore. I need to go and do an ERCP. ERCP, like I mentioned, is done endoscopically, and that is the diagnostic and a therapeutic tool. So it's the one right there. We're able to see the stone and then directly go ahead and remove it with the endoscope. And ERCP isn't typically done directly if you were not 100% sure that your patient has gallbladder, common bile duct stones. And MRCP is always the first thing that you're doing. So the surgical management of this disease, there is essentially only one management, quote unquote, is the laparoscopic cholecystectomy. It's the one that is done directly. We did it robotically in my hospital, and I know that a lot of hospitals in the United States do it robotically as well. It can or be done laparoscopic cholecystectomy, or you have an open cholecystectomy, but that is only done in rare cases where it did work laparoscopically, or I have a challenging patient. But laparoscopic can honestly be done with anything. We had a patient who had very high BMI, it was like 67. And when you're doing these surgeries, you do need to blow in gas to the belly. So we aren't sure if we'd be able to fully open the belly to have a good visualization of it, but it turns out that we were able to do it. So this just goes to tell that you do need to try the laparoscopic way first. Obviously, there's less post-op pain. There's a faster recovery, shorter hospital stay. Like I said, these are done outpatient, so it's in the morning and then out in the afternoon. There's obviously complications to the surgery, just like any other surgery. You can have accidental cutting if you're not looking at your anatomy properly, cutting the cystic duct instead of the artery or whatnot. Or you could have a bile leakage, which can also happen. So these are not my photos, but I wanted you guys to be able to properly visualize everything that I'm saying. So this is what a laparoscopic cholecystectomy looks like. So this is what I meant when I was saying misidentification of anatomy. When you are in the patient, this is exactly what you see without the arrows, obviously. So it makes it a lot harder. You have your cystic duct and your cystic artery. When you're doing it robotically, you're able to switch your visualization, and you can actually see it this way with the green light, which allows you to see the blood flow properly. So you will very commonly see your surgeons switching between both views. Once you've correctly identified your cystic duct and your cystic artery, you can go ahead and clip them. So what we tended to do was 2 proximal and then 2 distal clips, obviously in case one of them opens, we always have a backup. You would clip your duct and then your artery, and then you just go ahead and cut right in between. So like these are done laparoscopically, robotic laparoscopically, you have 4 small incisions. Like I said, it's less invasive to the patient, because then your patient's only going to be left with these 4 small scars. You basically input your trocars. The three of them are 8 millimeter trocars, and then you have one, which is your assistant trocar, which is going to be 5 millimeters, a lot smaller. The gallbladder right here, you can see is removed. It's removed by the umbilicus. So that is going to be the most painful area for your patient post-op. So these are 2 gallbladders right there filled with stones. This is the one on the right, which is typically filled with small stones. We've actually seen 2 of them. And when you remove them, so when you remove them in a specimen plastic bag like that, and you can actually feel around it. It honestly feels like a little stress ball. You just touch the little stones, but you can't properly move them around. There was one patient that we had which only had 1 stone in their whole gallbladder, and you're actually able to just slide it through. And we removed him with just 1 stone. So that honestly just goes to show how big the amplitude is for cholecystectomies. 1 stone can be so painful for one patient. And it can be a whole lot more painful for them than having this many stones. It honestly all depends. And then this is an open cholecystectomy. This is what it looks like. Obviously, a lot more invasive, and your patient is going to need a lot more post-op care. The hospital stay is going to be a lot longer. So we can all agree that this gallbladder does not look normal, right? It is not beautiful and pink like you would expect it to. So this is exactly one of the complications that I talked about before I mentioned. This is empyema. So this is the worst case of an acute cholecystitis. So an obstruction in the cystic duct, like we said. The gallbladder is going to be filled with pus, which is white, but we can see that here, when they're deflating our gallbladder before removing it, it's red. Red is also, it can just mean damage to the wall. It can also mean gangrene. Gangrene is when your gallbladder wall lacks blood flow, and you just get an accumulation of blood inside. So this is what empyema would look like. Obviously, not great. You can't remove the gallbladder just like that because you could risk spillage, and we absolutely do not want that in the abdomen. So deflate it before. And then we can see at the bottom, as they're closing up, injecting lidocaine, this is how big the wound is. So obviously a whole lot bigger than just having your 4 small cuts, right? And a whole lot harder to manage post-op. So essentially the key takeaways from this presentation is that gallstones disease affects millions and millions of people. It is something that you see so often in the clinic or at the hospital. And I think that's really important to understand how big the clinical representation of it can be. Of course, we're going to have pain, but you can, as I said, have some patients that have no pain at all, and then all of a sudden it just flares up like that. It does obviously cost a lot for the patient, and also millions for the hospital yearly. It's very important to diagnose this early on to prevent any complications. Laparoscopic cholecystectomy is the one that's done all throughout. It's the gold standard, minimally invasive, faster recovery, fewer complications, and short hospital stays. And then ERCP is done for common bile duct stones, and it is therapeutic and also diagnostic because an MRCP is only diagnostic. Yeah. Yeah, well, that's essentially it. So thank you.
So thank you, Mrs. Dalla. We would like to invite the next student presenter, Mrs. Kristina Yevkova, to the stage.
Yep. Like that?
Good afternoon, everyone. We would like to discuss about organized background organ society. So medicine is moving forward faster than ever, and scientists keep exploring new ways to push its limits. And one of the most exciting breakthroughs these days is the development of organoids, lab-grown organs. Just a few years ago, culturing a cell in a petri dish that could mimic and act and look like a real human cell seemed impossible. But now it's changing the way how we study diseases and develop treatments. So yeah, organoids are made from stem cells in a petri dish. And as they grow, they start to mimic the structure and function of real human cells. They are especially useful in cases where biopsies are not possible, like in brain diseases, because scientists they take a few skin or blood cells from real human organs, and they turn them into organoids that could model the function, so they could predict the treatment, and so they could predict the effective treatment and post-operative circumstances. Also, for instance, organoids can be grown into tumor cells, and this event is under development right now because tumoroids are an essential part of exploration since chemotherapy drugs can be developed, and this will help doctors choose the most effective treatment in the future. So here you can see how this is all organized.
So I will tell you how organoids are made. As it was mentioned, they are grown from stem cells. It could be used to embryonic stem cells, induced pluripotent stem cells, adult stem cells, and also cancer cells. They are incubated in Peris systems and then transformed into free masses with cell morphology and function. Important fact that cells which are grown into these systems, they aren't able to obtain normal cell morphology interactions in vivo. So signal transduction, intracellular communication, and function, like layer functions forward, they are lost into the system. So cells which are grown in a 3D system, they have a high degree of similarity with their parental cells. They have ability to self-regenerate, to self-reflect, and to have the same biological functions as cells in vivo organs. Then these three organoids, are transferred to gel-like matrix. Matrigel and synthetic hydrogel, incubated at 37 degrees, and also various growth factors are added to organoids. For example, cardiac organoids require activin A, BMP4, then BMT3 to induce their messenger. After that, it is established their three-tier layer, mesoderm, exoderm, and endoderm. Actually, their full maturation requires from 30 to 60 days. Unfortunately, they're short-lived, but to increase their existence, it is required to once or twice per 10 days to change their extracellular matrix, so they change their medium and passaging. For passaging, it is needed to remove medium, then grow organize into small parts, and place it to flat, to store. Then they're essentially cooked, washed, and you have to repeat this process once or twice per 10 days.
So there are some factors that can reshape our approach to medicine, and I would like to go through them quickly. So first of all, it's personalized medicine. Thanks to advancements in medicine, we can now culture organize many patient cells, so we can predict the most effective treatment for individuals. like I mentioned, and in cancer cells. Second, it's disease modeling. Now there are the structures called assemblies are developing that combine several organoids together from different tissues, like from brain and spinal cord, so that doctors can imagine the interaction between different systems, which is very critical factors in neurological or metabolic disorders. Third factor, it's drug discovery and testing. Thanks to technology, we can now check if the specific drug could be efficient in specific treatment, and then also could minimize animal testing. Fourth factor, it's regenerative medicine. So the potential of organoids is to predict if we can transplant organoids into human cells so they could replace or even regenerate the damaged human tissues. The next point, it's reduced reliance on animal models. As I said, it's a very crucial factor in developing organoids, since there are lots of disadvantages of animal testing, and organoids are now expected to replace them. And the last point, it's artificial intelligence, but I think it's the most it's probably the simplest way to organize organoids, because artificial intelligence is a huge factor. It plays a huge role in determining disease patterns that it could also help doctors.
Let's consider advantages. Realistic 3D structures. Organoids preserve the look and function of real organs by arranging cells in every system. They actually mimic architecture and function of human organs. This means that they maintain complex cellular and molecular function, which are lost in 2D flat system, making them ideal models for various purposes. Realistic cellular communications. Organoids facilitate crucial intracellular and cell-to-cell communication that govern tissue properties. Unlike standard cultures, organoids are composed of various cell types, which allows researchers to discover how cells interact with each other and with the surrounding extracellular matrix in realistic 3D environments. Human-specific modeling. A major benefit of organoids is their ability to directly show, once again, function and shape, because they are composed of human cells. They eliminate inaccuracy caused by species-specific models in animal models, making them a successful tool to discover how human organs work. Personalized medicine. Organoids can be derived from a specific patient, including their tumors, disease features, and imaging genetic type. This allows to adjust the treatment and make prognosis of diseases. And the last, high throughput and cost-effective testing. Since organoids are closely resemble real in vivo systems, they are incredibly effective for drug testing. Researchers can generate numerous organoids from a small number of human cells and simultaneously make drug tests. This allows to minimize gap between lab results and patient response, bringing faster drug generation to patients.
So, thank you very much for your presentation.
Get to the conclusion.
Yeah,
but we're on time.
Yeah.
Can we just talk a little bit about disadvantages, and then we'll go for
Yeah.
2 minutes.
So, despite their incredible potential, organoids still come with several limitations, and I would like to point out the most important ones. So, first of all, they are not much mature. They don't yet match the full complexity and functionality of human cells. So they, even if they mimic the functions, they still do not serve the real purpose of human cells. Second one, and the third one, it's lack of vascular systems and immune system, which could be a detrimental factor if we want to discover immunotherapy drugs. And regarding vascularization, if we do not deliver blood and oxygen to those tissues, they will just not survive. And and I would like also to mention the last one, it's insufficient monitoring. Since we cannot monitor organoids, is still a challenge. We cannot predict how they will behave or how they will what function they will serve in a real human cell. Thank you very much.
So thank you. We would like now to invite our next student presenters to the stage, Mrs. Maria and Mrs. Ermioni.
Okay, so hello everyone. So let me ask you a question. What could cause sudden shortness of breath, chest pain, and even death within minutes, yet often goes undiagnosed? The answer is pulmonary embolism. I don't know how to which button to push. This one? Thank you. Sorry. So, pulmonary embolism is the blockage of an artery in the lungs that has moved from elsewhere in the body through the arterial circulation. The composition of the embolus varies. Most likely it's a thrombus, but it can also be septic material, cancer cells, air bubbles, amniotic fluid, or even fat. Did I close it? Okay, sorry. Okay, regarding the origin of the thrombus, 90% of the emboli originate from the deep veins of lower limbs, and most probably from the common iliac, femoral, or popliteal vein. Okay, so the Virchow triad highlights the three fundamental mechanisms underlying thrombus formation, which include hemostasis, endothelial injury, and hypercoagulability. Okay, now regarding the pathophysiology of pulmonary embolism, it could be divided into the hemodynamic, pulmonary, and anatomical effects. Now, the hemodynamic effects rely on the size of the embolus, the area of the lung block, and the condition of the cardinal or lung parenchyma. Now, the constant cycle occurs during the proximal function during pulmonary embolism is the one you can see in the diagram. Firstly, we have the emboli and the vasoactive mediators causing a rise in the right ventricular outflow. Then that leads to a compliant and thin-walled right ventricle dilatation that will lead to a decreased right ventricle output. That will cause the right ventricle dilatation and depletion on the left ventricle, causing a decreased left ventricle filling and output that will impede the coronary arteries to have adequate supply, causing right ventricle ischemia. And as you can observe, it will lead to decreased right ventricle output and so on and so forth. Now, because of the damage on the lung parenchyma, the area affected during pulmonary embolism is decreased well, and we also have decreased PVO fluid. Those two will lead to a mismatch in the ventilation perfusion ratio, which will be increased in the embolized region due to low perfusion and will drop in the healthy region. And all of the above will cause more dead space and hypoxemia. Now, in 25 to 30% of the cases, there will be an open in the foraminal bladder due to high pressure in the right atrium,
that will cause the shunting effect from the right to the left. Okay, so now the risk factors can be divided into the inherited and acquired. The inherited include the factor V library mutation, prothrombin mutation, and some protein deficiencies that will basically disrupt the clotting process. And the acquired risk factors include surgery, cancer, estrogen therapy, aging, and obesity. And the symptoms include shortness of breath, chest pain, fainting, and lower extremity pain, and hemoptysis. But none of them can be pathognomonic.
Okay, so while the electrocardiogram is not diagnostic for PE, it may show signs of right heart strain, which includes seems tachycardia, right ventricular strain, right bundle branch block, and the C1q3 T3 pattern. Likewise, the chest X-ray is useful to rule out other conditions. However, it may the findings might be indicative of PE, and these findings include Westermarck sign, Hampton's hump, and Pallas sign. And it is important to mention that a normal chest radiograph does not exclude a possible pulmonary embolism. So what can arterial blood gases tell us in the context of a suspected PE? Could hypoxemia, hypocapnia, or respiratory alkalosis be pointing us towards pulmonary embolism? These findings, while not diagnostic on their own, could raise the suspicion of a pulmonary embolism. So, there are three ways to establish diagnosis. The gold standard for diagnosis is the computed tomography pulmonary angiogram, next the ventilation perfusion scan, and lastly the pulmonary angiography, although its use has fallen out in recent years. Okay, so it is very, very important to mention that all test results must be interpreted with reference to the Wells criteria, which are these ones. Okay, so a computed tomography pulmonary angiogram provides detailed images of the pulmonary arteries, which detects the severity of PE by assessing the size and location of the clot. It provides a high level of accuracy in confirming and excluding the presence of pulmonary emboli. And as I mentioned before, it's the gold standard for diagnosis. So a ventilation perfusion scan evaluates the airflow and blood flow to the lungs. A normal VQ scan rules out PE. A low and intermediate clinical probability scan along with low probability scan also rules out PE. A high clinical probability along with high probability scan leads to a PE diagnosis, and any other combination needs further diagnostic evaluation. Okay, so before mentioning another diagnostic tool for PE, it is important to understand the D-dimer formation, which is a fibrin degradation product. So, during fibrinolysis, plasminogen activators are released, triggering the conversion of plasminogen to plasmin, leading to clot breakdown and D-dimer formation. So, I'm going to say it once again, patients with high probability for PE, a CTPA must be done. In patients with low or intermediate probability for PE, a D-dimer test is done. So D-dimer test is a highly sensitive blood test used to help rule out PE by measuring the fibrin degradation products. A negative D-dimer test rules out PE for patients with low or intermediate clinical probability. A negative D-dimer test is not helpful for patients with high clinical probability, and with a positive D-dimer test, we proceed with the CTPA. And I want to mention that D-dimers become less useful as the duration of hospitalization increases due to thrombus formation.
Okay, now there are two main treatments for pulmonary embolism, but in order to choose which one to use, we have to investigate the severity of the embolism. But mainly we need to focus on giving the patient enough oxygen and stabilizing their hemodynamics. So, now, the patients can be divided into two categories: the ones without shock or without cardiorespiratory compromise that are in low or intermediate risk and they need anticoagulants, and the patients with shock that are in high risk and need antibiotic therapy. Now, the anticoagulants used are located away heparin and Marinos, fractionated heparin, which are the main anticoagulants used for. We can also use vitamin K antagonists and direct oral anticoagulants. They are prescribed mostly 3 to 6 months, but in some cases, treatment will be indefinite. But in order to prescribe, we always need to calculate the benefit of risk ratio. And lastly, the difference between the two heparins is that low molecular weight heparin, often the Marinos, are always preferred. They have low chance of causing heparin from lymphopenia or major bleeding. And the main advantage is that they can be used subcutaneously without monitoring. And the fractionated heparin is used in patients with high risk of bleeding and severe renal insufficiency. These are the references, and thank you very much.
So thank you very much for your presentation. Now we would like to invite the next student presenter, Mrs. Khadija Ali. Hi. Sorry.
Hello, everyone. My name is Khadija Ali Aziz, and I feel honored today to come and talk to you about diabetes and tuberculosis, the comorbid burden of them, and a bit about the pathway that underlies between the two of them, and what we can do to help patients with both of them. So, I'm sure you know, just a bit about me. I'm a 5th-year student from University of Nicosia. I'm currently practicing in Paphos, my clinical years. I'm interested in internal medicine and the management of chronic conditions. And yeah, I like to do other stuff as well. Okay, so I'm sure you're all familiar with diabetes and tuberculosis because they are highly prevalent and there's a high incidence as well. Adults with diabetes are 2 to 3 times likely to get tuberculosis. And around 1.5 million people per year need integrated care for both of these. So early screening is really important. And to make sure that we combat the global crisis. So, okay. Diabetes is a threat to the WHO End TB strategy. That's the World Health Organization. The goal is meant to reduce deaths in tuberculosis by 95%, reduce incidence rates of tuberculosis by 90%, and make sure that no families are affected by tuberculosis. This was actually meant to be accomplished by 2020 and 2025. However, setbacks like COVID-19, funding, and missed diagnosis has really put us back. Additionally, only a quarter of people with multi-drug resistant tuberculosis actually get diagnosed with it, and only half of those can get cured. And lastly, there needs to be increased care for patients with both tuberculosis and HIV. There's also a huge triad of tuberculosis, HIV, and diabetes, but I'm not here to talk about that today. So the comorbid complications of tuberculosis and diabetes together show up with with increased symptom severity and prevalence of atypical symptoms than when diabetes and tuberculosis present alone. Common symptoms of diabetes are excessive thirst, excessive urination, weight loss or weight gain, while tuberculosis usually affects the lungs. When you have both diabetes and tuberculosis, you can come in with a range of symptoms, both typical and atypical, and it'll be more severe than when the patient has just one by themselves. So when both overlap together, it makes diagnosis more complicated and it makes diagnosing more complicated and slower, and it's more expensive. So, comprehensive management through early detection and prevention is essential. Routine screening tools for diabetes and tuberculosis are the glucose test, HbA1c, the MAN2 test, the Zile sputum test. All of these can be used for both conditions. Some have been shown to be better when someone has diabetes as well. For instance, MAN2 is preferred. Interestingly as well, CA125, the ovarian cancer marker, has been shown to be increased in elevated in some tuberculosis diabetes cases. Many high risk region within the WHO regions, there's about 30 of them, such as South Africa and Kenya, face delays in diagnosis and management due to poor infrastructure, staffing shortages, inadequate training, and limited resources, forcing patients to have to navigate a fragmented pathway to care, underscoring the importance for integrated referral systems. So I'm now going to talk about the pathophysiology between the two. So hypoglycemia, or poorly managed glycemic control and insulin resistance, weakens the immune system by affecting the antigen-presenting cells, that's the first three, and the NK cells as well. Eventually, this leads to makes it more susceptible for people with diabetes to contract tuberculosis, or to reactivate latent TB, which is why it's important to screen people with diabetes at initial diagnosis for tuberculosis with chest X-rays or sputum tests. Conversely, tuberculosis can affect the insulin-producing cells in the pancreas, which can lead to diabetes. Also, rifampicin, which is given for treatment of tuberculosis, can damage the pancreatic cells, leading to diabetes as well. It's like a vicious cycle where one can lead to the other one. Rifampicin also interacts with the liver CYP enzymes, which regulate glucose levels, and in turn, diabetes can affect the effectiveness of rifampicin, so making treatment more complicated. Finally, diabetic patients may require multiple BCG vaccinations to maintain tuberculosis protection. This bidirectional relationship between tuberculosis and diabetes underscores the need for early screening, timely intervention, and integrated management. Equally, effective communication ensures that the patients understand their risks and the importance of routine screening for both conditions, empowering the patients and making them feel in charge of their care, and significantly improving treatment outcomes. So that is the main takeaway from today. In summary, that diabetes and tuberculosis are deeply intertwined, and combating them requires integration in diagnosis, management, and communication to truly improve patient outcomes. That is all from me. Thank you so much. Any questions? Great, thank you.
Thank you so much, Mrs. Aziz. So now we would like to invite our next student presenters to the stage, all the way from the Royal College of Surgeons in Ireland, Mr. Polemidiotis.
Imagine you're a surgeon and one day in the operating room you make a mistake and someone gets hurt. Imagine how you would feel, imagine how those feelings would build, and imagine how it could affect you in your daily life. These complications are emotional and psychological events, and that's why I want to introduce surgical complication adverse reaction syndrome. My name is Mark. I'm a medical student. I was introduced from Ireland. I grew up in Canada, and here presenting today on behalf of the Surgical Fitness Research Pod, the group I work with, on the new term scars. So just a quick background, the intraoperative complications, or IOCs, are when surgeons make a mistake or something happens in the operating room, and it can lead to events which have an impact on the patient, but also there's this term that's coined second victim syndrome in 2000 by Wu et al. And that outlines the healthcare providers' reaction to the adverse event, how they feel and how it can affect them. So it captures emotional and somatic events. It can not just be emotional, but it can also affect how they work, how they sleep, how they live, and it can cause real health impact, which is why it's an important syndrome. It can lead to burnout, avoidance, and people retiring from the profession. So it can cause real problems to the surgical community. This is a diagram inspired by Wu et al. In 2000. So this is kind of the start of it. The initial kick, the fall, and then the recovery, and then the long-term consequences. A lot of times surgeons not able to get back to their previous state of function. So the methods of the research paper, we want to define scars, and we want to highlight the inadequacy and support for institutions, because a lot of times the adverse events happen and there's no help for the surgeon, there's nowhere for them to go. And right now, you see later on in the study, you find that most of the time they're just relying on casual peer conversations in hallways, and there's no structured debrief or anything to help these people and these surgeons, the physicians, get better after the event. So we did a PRIMSA guideline and a Prospero study. We went through PubMed, and we had 14 studies that reached our total inclusion criteria that included surgeons and then the self-reporting of how they felt afterwards. So 2,300 participants. And here are the results. It's a meta-analysis. So we took all the results, and out of everyone who answered questions on guilt, 2/3 of them said they felt guilty about the topic. Anxiety was more than a quarter, insomnia, and these other physical symptoms are also very high. And depression and even PTSD-like syndromes, 15% of people met the criteria for PTSD, which is a closely related syndrome, but has its distinctions, which we'll go into later. As you can see here, guilt was the most common, but all these things were very negatively impacting on the surgeon's life and how they continue to practice medicine. So the second part, after we defined the symptomatology, was to try to find the institutional support and how the hospitals and where people are working are helping them, which is very inadequate at this point. Like I said, most of people are only relying on peer support, which is just casual conversation with a colleague. This is very important, and our research group highly supports that, but it should be a secondary adjunct to the real form support that they get. More than 30%, 37% of people have got no support at all, meaning they didn't talk to anyone and they just kind of try to deal with the situation on their own, which is leading to the burnout and the early retirement and the risk adverse reactions, which is a huge problem. And only 7% of people received formal support. So about half of people will talk to someone, but only 7% will actually go to a formal support class, which we think is very low, and it's a big problem in medicine. And a lot of the problems is accessing support, knowing where the supports are, and also not feeling like they're going to get judged and not feeling like they're going to be looked as a bad surgeon by coming forward with these mistakes, which is often an issue in surgical medicine, is the stigma between talking about mistakes and when you made a mistake. Even though everyone does it, no one seems to be talking about it. So the impact we've talked about a lot. I'm picking up this quickly, but burnout, sleep, and risk adverse is the big one that I haven't touched on a lot yet. So surgeons have been shown to not do procedures the same way or avoid procedures in total. And in an area where there's a shortage of surgeons, especially in Canada where I'm from, this is a huge problem because we need surgeons working, and having needless retirements just because of something that can be avoided is a huge problem in medicine. So it's a very important thing to address. So the definition, the way it differs from post-traumatic stress is it is physician specific. And there doesn't need to be one of the presentations actually mentioned today, PTSD, there needs to be very specific point, and it has to fit into a specific criteria of what happened, like a near-death experience or perceived near-death experience. This could be anything that happens in the operating room. It could have a bad result or not, or it could just be something traumatic and it can happen to anyone in the operating room. And if you have more than 3 of anxiety, guilt, depression, insomnia, anger, or somatic symptoms, which almost everyone, if they have one, have more than one, and then that lasts for more than one month, then we could diagnose you with the SCAR syndrome. So the institutional gaps, like we said, more than 90% of people didn't have any structured support. A lot of the papers we looked at quoted M&M, or morbidity mortality meetings, as support, but it really isn't. This is something that is important in medicine, but it's kind of just fixing mistakes that happen and fixing technical issues. It very rarely, if ever, supports the surgeon and what they're feeling. And even worse, it does kind of build into that foster of blame and pointing fingers, which is not good for anyone, especially people who are going through something traumatic. So a big part of the things that we need is a cultural shift from blame to learning. So our recommendations for a research group at the end of our paper, they need to be a confidential psychological support that's built into every hospital that performs surgical practices. The structured debriefs need to be present, and we want to include peer mentoring in that. We don't want to disregard that because surgeons did say it was helpful, but we just want that to be a secondary thing towards after the official treatments. Protected recovery time. No surgeons received any health recovery time or time off, even if they said they needed it, because that just wasn't built into the surgical plan. So that's something that they asked for and we think is very reasonable. And long-term follow-up, even when there was that 7% who got formal complaints, there was a one-off thing right after the incident. And then 3 days later, there was again no support. So 3 days to a week after support, pretty much 100% of people who had an adverse event happen had no help. So we're trying to fix that. And that's long-term follow-up is a big point of our research paper and trying to improve better. And then just recognizing it as a formal disease and a formal diagnosis. A lot of people just in surgery are just told to suck it up, and it's kind of how it goes. But in diagnosing this is really important. It's going to help a lot of people and a lot of physicians and a lot of the patients that we met. So just to conclude here, like we said, it's a distinct disease. It's under-recognized. It's harmful for surgeons, but also, again, harmful to the medical community, for health and for patients themselves. Formal recognition is required, and right now there's a lack of the support we need to be move forward. So thank you. Any questions? You can, I know we're short on the line, but yeah.
I'm gonna not be professional for a second.
Yeah.
That was really cool.
Thank you. Yeah.
It was great.
There's a lot of, I've had some other papers on mental health as well, so it's something I'm interested in, and surgeons are particularly bad at sharing how they feel in general, so it's one of those things that I thought I'd do for everyone.
My question would be, okay, so I don't want to be a surgeon, but I do unfortunately have to go through surgical rotation. Do you think this is could affect medical students as well?
Of course. So the actual start of this paper was something else I did, which was called Schwartz round, where medical students again go through a lot of stuff in medicine, and we're exposed very early on to a lot of very traumatic things, like death or diseases, or even just being put in a situation they're uncomfortable with. And again, there was no resource for them to come out and talk to people about how they're feeling or get past that. It was just kind of like, it's kind of a culture, just like, okay, like show up the next day and kind of push it to the side. So it's very useful, and our exclusion criteria, we did surgeon specifically because it's a group that's affected the most. And like you said, you kind of have to narrow it down eventually. But it is a very important thing in all of medicine, and everyone, students, nurses, everyone involved. Yeah.
Thank you.
Thanks.
Thank you, Mr. Blemidiotis. Now, we would like to invite the next student presenter, Mrs. Christia Jangari, to the stage.
Good afternoon, everyone. My name is Christia Jangari, a third-year medical student at UBC. Today, I'll be sharing a focused look on melanoma, why it matters, how we can spot it early, its diagnosis and treatment, and also the prevention that truly saves lives. Did you know that one person dies worldwide every hour of melanoma? And most of those deaths can be prevented through something as simple as prevention and awareness. So now raise your hands if you ever had one of these. Any moles? Anyone? Okay. Pretty much everyone, yeah? These are nevi or simply moles. These are clusters of pigment-producing cells of the skin, and most of them are completely harmless. Some are congenital, which you could like be born with them, or acquired with over the time. They can appear flat or even raised, and they could be light or even dark. But not all moles are the same. Some we have also junctional, the compound, also the intradermal one, and the combined nevus. We also have the blue nevi and the atypical ones, which these are the most concerning ones. So basically, it's not about having moles, it's about knowing you're normal and noticing any changes. There are three main types of skin cancer disease: the basal cell carcinoma, the squamous cell carcinoma, and melanoma. Melanoma is the least common one, but by far the most aggressive and dangerous. And although it accounts for only 1% of skin cancers, it causes the majority of deaths. And it begins in the melanocytes, which are the pigment-producing cells of the skin. When ultraviolet light from the sun or tanning beds damages the DNA, these cells begin to grow uncontrollably, and they invade deeper tissues or even spread to other organs. That's why melanoma is so highly metastatic and life-threatening if left untreated. Also, cases are rising, especially among younger adults, and particularly in women under 40 years old. The good news is that if melanoma is detected early, it's highly treatable, and it makes awareness and early detection absolutely critical. So these are some pictures of a real-life patient. He's a 79-year-old man. He's suffering like now around 1 year of melanoma. It started like as a mole. This man used to work in agriculture outside the sun, so he got exposed during early childhood with sunburns, and you can see it spread all over his skin from head to toes. I got his consent, by the way. So these are some causes and risk factors of melanoma. They could be environmental, and also they could be genetic. The environmental ones is UV exposure from the sun or tanning beds. Sorry. Yes. And the biggest one is no surprise, the UV exposure. You can also get sunburns from childhood, and they also increase even more the risk of melanoma. People with fair skin, red, blonde hair, or light eyes, or people with like alopecia, they could also have higher risk of getting melanoma, unfortunately. And also having many moles or freckles, it's also a higher risk. Genetics like rare inherited syndrome or familial atypical multiple mole melanoma syndrome increases even more the risk of melanoma. History also matters. Patients with previous melanoma or other skin cancers, or immunosuppressive patients with immune system that is weakened, for example, by illness, transplant, or certain medications, the risk even rises among them. Now, if you remember anything from today, let it be the ABCDE rule. It saves lives, actually. You can also detect it alone if you know it. Okay, so melanoma self-assessment method. A stands for asymmetry. It means the mole itself looks uneven. One half doesn't match the other. And then we have the border, which refers to the edge. If the outline is irregular, jagged, or blurred, that's a warning sign. C refers to color. Watch out for uneven or multiple colors within one mole, like shades of brown, black, blue, white, or pink, within the same spot always. D represents diameter. Anything larger than 6 millimeters, like around the size of a pencil eraser, should be checked. Also, E stands for evolution, and if you notice any changes in size, shape, color, or sensation, you should immediately check with the doctor. If a mole also itches, bleeds, or crests, it's a warning sign, and you should visit the doctor emergency. So let me ask you this one. Let's test our eyes for a second, and based on what we have already learned in the previous slides, which one do you think is more suspicious? A, B, or C? Yes, C. Okay, any other? And why? Yes?
A has multiple colors, and in the edges, it's a bit different because.
Yes, right. So actually, A and C They were C, you have to biopsy to see if it's an actual melanoma, but A was the one which was diagnosed because of the multiple colors, and if you cut it in half, the two halves don't match each other.
And C, what was C?
It's
Just like a bit of a.
it's a warning one because if it continues and
Right.
like changes in size, it grows more, then you have to check it.
Right.
So there are different types of several types of melanoma. We have the superficial spreading, which this is the most common one. It spreads horizontally, and it also shows irregular colors, as you can see there. It's more superficial though. The nodular one, the one at the end, it's the most aggressive one. It's a raised one with a dome shaped, and it's more common in darker skin colors. The lentigo-malignant melanoma, the first one, is usually seen in older adults who were like got sunburns during their childhood, and it's more sunburned areas like the face. Acknowledgements melanoma, it doesn't appear here. This is the next slide. We're gonna see about it. It appears on palms, soles, and under the nails, and it's more common in darker skin tones. So recognizing these forms helps the clinicians diagnose melanoma at different stages. There are also hidden melanomas. I was actually surprised by that. I didn't know that. During my research, I found that not all melanomas could appear on some exposed skin, and they can hide in some protected areas, like the toes, the palms, the soles, the scalp, and even in genitals. There are types such as the mucosal melanoma inside the mouth, the nose, or the vagina, the ocular one, which appears in the eye, and the acral edegenous melanoma, which is more common in darker skin tones. That's why full body checks are crucial, and even in places we don't usually look at. So, while AI labs can help flag risky moles, they should always be alongside with professional evaluation, not instead of it. So if you're like wondering whether you have something, you can always ask ChatGPT, but always check it with your doctor. Diagnosis starts with a clinical exam. It's a comprehensive history patient, taking history and a full body inspection. Next, we have dermoscopy, which lets dermatologists see beneath the skin surface for subtle patterns. It's a device with a light, and you can see underneath the skin what happens. But always, if a lesion looks suspicious, we have to remove it with excisional biopsy, where we take the mole with a little bit of surrounded skin in order to be sure about it, and we send it for histopathology. The Breslow thickness measures how deep the melanoma is, which determines its stage. For tumors thicker than 1 millimeter or with high-risk features such as ulceration or high mitotic activity, a sentinel lymph node biopsy is performed to check for nodal spread. So, the treatment depends on the stage of melanoma. If we have the early stage of melanoma, which is stage 1, melanoma is treated with surgical excision. As we mentioned before, we take the mole and the surrounding skin and we remove it, and it's often curative on its own. Then for stage 3, where lymph nodes are involved, adjuvant therapy may follow either with PD-1 immunotherapy or the targeted therapy, BRAF or MAK inhibitors, if there is a mutation present. Actually, in 50% of the patients, there is a BRAF mutation in their cells due to the melanoma. So for advanced stage 4 cases, doctors use checkpoint inhibitors or targeted drugs, sometimes combined with radiation also, in order to exclude like maybe metastasis in the brain and the bones, and in order to have symptom control and provide prolonged survival and a quality of life. Treatment is also guided by a multidisciplinary team of doctors like dermatologists, oncologists, pathologists, surgeons, and even psychologists in order to prolong the quality of life of the patient. Survival is around 99% when localized, and it falls below 30% once metastatic. So there was a study in Cyprus in 2022 conducted that found that 59% of people check their skin. So of us, 4 in 10 people never do. Most use sunscreen only on holidays, but 59% neglect daily UV exposure. And we forget that UV light also passes even through windows. The study showed an education gap higher an education gap. If higher education meant more awareness, and an age gap that peaks concern between 30 to 59 years old, while the most worrying part is that younger adults who spend most time in the sun were the least concerned, thinking it will not happen to them. So prevention and awareness is important. We have to, and it's powerful. First of all, we have to all avoid tanning beds and sunbathing. We all do that, right? Okay, we have to seek shade, wear protective clothing when in the sun, like sunglasses or caps, and always use SPF 30 broad spectrum sunscreen, which must be reapplied every 2 hours, every day of the year, especially in countries like Cyprus, because we have 9 months out of 12 sun. But remember that UV rays even reach you on cloudy and even in snowy days.
Should we move to the conclusion?
Yeah.
To conclude, thank you.
These are my references for Mastic research. Thank you. To wrap it up, melanoma is one of the few cancers we can actually see with our own eyes. Awareness, self-checks, and sunscreen are small habits that truly save lives. And as future doctors, we have the privilege to spot what others might overlook. And sometimes a simple observation can change your life. Thank you for listening, and don't forget to always
Thank you so much, Mrs. Shankari. Moving on to our next student presenters to the stage, Mrs. Christina Evangelio and Mrs. Tandem.
Hi everyone, my name is Christina and this is Canadell. And today we're going to be talking about a topic that's very important to both of us, and that's why women are misdiagnosed more often in medicine, and why it keeps sending to diagnose women in general. So the topic that we're going to be coming back to a lot today is diagnostic. So what is that? It's the time between when symptoms start and when diagnosis is officially confirmed. And what we're seeing is for women, this delay is often significantly longer than it would be for a man with the same condition. Cancer, ADHD, diabetes, you name it, it's probably taking longer to diagnose a woman than a man. And that delay has real consequences. The longer it takes to diagnose a condition, the more it progresses and the worse the effect it has. So just a quick question. What do you guys think is the average diagnostic delay for endometriosis? So hands up for A.
Yes, it was on the band.
Hands up for B. And C. Next slide. Yeah, okay, next slide. So yeah, 7 to 8 years, which is ridiculous. And how much more likely are women to receive a misdiagnosis than a man? Hands up for A, 20%. B, 66%. And C, 33%. So yeah, it's actually 66%, which is ridiculous. Again.
So when we talk about why women get diagnosed so late, it biologically a huge role too. So for example, first of all, our symptoms are different. So for instance, a woman having a heart attack might have symptoms like nausea, fatigue, jaw pain, back pain. So it doesn't fit the exact needle pattern of a heart attack. That's why many doctors often miss it, and it ends up with losing their life most of the time. And then on top of that, there's the role of hormones. For women's hormones, they affect everything from how symptoms appear to how drugs work and their fatigue. And for decades, medicine only focuses on men's physiology and how it works for that rather than women as well, because it's more complicated for women. On top of that, some conditions are unique to only women. So endometriosis, PCOS, menopause-related disorders. These conditions have been underfunded and underdiagnosed for decades. And finally, we can't ignore the research gap. Most medical studies only focus on men. They're studied on men only. So our entire understanding of disease and how it works is based on only half the population.
And it's not just biology that plays a role, it's also social and cultural attitudes as well. There's still stigma around women's health, menstruation, childbearing, menopause, and they're often taboo, they're not spoken about enough. Women are often labelled as emotional, overreacting if we complain about it. And then on top of that, we have barriers like limited access to education in some countries, which makes it harder for women to advocate for themselves or even recognise when something's wrong. And then we have the healthcare system itself. So think about it, in our lectures, how often are we taught how pathology presents in men and women, the difference between them? We're not. Doctors aren't trained to recognise sex-specific symptoms. And that's why these referral pathways can take months, even years, as we can see here. To make it worse, the clinical guidelines that we're working off of aren't written with gender consideration in mind. So the system literally isn't built to recognise these symptoms early. So let's talk about the human side of this now. With regards to pain, many women describing is told it's just anxiety or it's just how it is. And imagine how validating that must feel when you know something's wrong. I think it's really important as future doctors to remember that our patients know their bodies better than anybody else, and we should believe them when they're complaining. And also, just because a symptom is common, it doesn't make it normal. And beyond the emotional toll, the consequences are really serious. Girls are missing school, work, the symptoms are getting worse, and it even has high mortality rates.
No, the consequences of delay are serious. It affects not only health, but quality of life, mental well-being, and finances too. So first, of course, the impact on everyday life. You miss school, work, opportunities, important celebrations. Then there's a cost to health itself. Of course, the longer an illness goes untreated, the worse it becomes. And then there's the mental toll. We can't forget about that. Imagine being told that your pain that you've been feeling for months or years is just stress or it's just in your head. It affects your mental health, of course. And finally, there's a financial cost because more hospital visits, more tests, not just for the patient, but for the whole healthcare system. So something that could have been treated very easily and quickly becomes way more complicated and way more expensive. Now that we've seen how biology and diagnostic delays affect women, let's talk about what that looks like in real life. I'm going to share two real stories of women who had heart-related problems. One who almost didn't make it and one who unfortunately actually didn't. Case one, imagine this 67-year-old woman, maybe a mom, maybe a grandma. She comes into the hospital watching her chest. She has high blood pressure, she was a smoker, she had diabetes. So basically every risk factor for a heart attack. But she isn't treated in time and within just 24 hours, she passed away. Later on, they checked the autopsies and it was revealed that she had multiple heart attacks. So chances are that if this same exact patient was a man, then the doctors would have jumped into heart attack diagnosis right away. But because she was a woman, her pain was undermined, let's say, or downplayed. Next. Oh no. Yes, perfect. This is another case. This is a 47-year-old woman. She comes into the hospital with a burning feeling in her chest. And instead of the doctors checking her heart, checking if everything's okay, they just assume that, oh, it's probably just reflux. And then after some days passed, her diagnosis or her condition got worse. And then when someone actually decided to check, they realized it was not reflux at all. It was coronary heart disease. But by then, her condition was already gotten so much worse.
So this is now a true story from Nicole. Her symptoms of endometriosis began when she was 13, which is the first of her period. She endured extremely heavy and painful periods all throughout her life, and it got to a point where every month she was being put into hospital with a drip. She'd actually been told by a doctor that it was all psychosomatic and that she was bringing this on herself. And then 20 years later, at the age of 33, she underwent a laparoscopy which showed stage 4 endometriosis. So just imagine the pain and the frustration and the confusion that could have been avoided if she'd been listened to in the first place. So then,
So after hearing these stories, No, that's the wrong position. After hearing these stories, it's impossible not to feel something, unless you're a robot and you don't have a heart. You know, like these women could be our patients, our partners, mothers, sisters. So that's why I want to end the message with a message to all of us, because we're all future doctors in this room. That's our manifest, right? We've already have been discussing the future. So, dear future doctors, not just cardiologists, doctors, all specialties, do remember that when the symptoms do not always mean the textbook. It may sound vague, it may sound less typical, but just because it doesn't match what you've been taught in the textbook, it doesn't mean that you shouldn't study it more and listen to them more. So listen carefully, believe your patients, and question what you were taught if it doesn't fit what you see. So let's be the generation of doctors that don't let women's pain go unheard. You know, our presentation, the title was Unseen, Undiagnosed, Unheard. Let's not let that happen. Let's be the generation that changes this category. And so after hearing all of this, what can actually be done to improve women? First of all, we need to increase female representation in research. Very self-explanatory. We need to study women even more than men, actually, because of course, as I said previously, we're more complicated due to our hormones, our biology. So we need to study women even more than mastic. And also we need to train doctors on sex-specific medicine. So medical education has to move beyond the one-size-fits-all, where we only care about the, like Christina said, the straight white man. No, right? So, because of course, drug metabolism, symptoms, everything can be different. So it needs to be studied more, way more.
Exactly. I think public awareness campaigns would also help women to feel more empowered and advocate for themselves more, which is necessary, because we're all entitled to good care. So we really need to push that. Being seen and heard saves lives. And I think this last quote just sums up this presentation. Women are not small men, and medicine must reflect that. The system is not built for women or any sort of minority in that passage age.
So let me just say one thing for this. I mean, what you wrote about the solution, it's right. But I don't think this will solve the problem. The problem will be solved by educating men to respect women and hear women and listen to women, because the indifferences for female patients stem of course from social cultural things, but also from misogyny.
Absolutely.
And I think it actually depends on the doctor, because my doctor, he's a man, he listens to me, he respects me, he's not like, oh yeah, you feel like this, oh you have this. He's not like that. So I think, yeah, men, like from an early age, should be educated on that. But that's impossible to be done everywhere in the world.
Absolutely. Thank you for your.
So
we now conclude the second block of the oral presentations. We would like to thank all of the student presenters of the time and effort they put into their work, and for all the course share their findings with us. Please see us later for the third block and actually the final block. Thank you so much.
Before we move on to our roundtables, our open discussions, we just want to take a quick conference photo. Would that be okay with everyone?
Please, over here, organizing committee.
Just for the organizing committee.
Organizing committee, everyone, the organizing.
Sorry, I should have clarified that.
Yeah.
Maybe I do it in the center.
I'm doing my presentation now, so I need to download it.
There's a case store.
Wait, how does it, why is it not presenting?
Così,
Eh?
così lo facciamo.
Oh, chiude tanto, capabilità max.
Max.
Yeah,
Sì.
within schedule. That's coming.
Vai.
Yes, please.
Right, we're gonna move on to our next section.
Parkinson's, the fascination.
No. What is this?
Again. Amazing. Okay, right. So hi everyone again for attending our second open discussion session. This open discussion will focus on two groups of students. One is to it involves the topic of sexual health, both men and women. So for the women's sexual health discussion, we would first like to welcome at the stage our chairman, Ms. Aphrodite Pascoe, and Ms. Costandino.
Forward, so.
Okay. So, hello everyone. My name is Aphrodite Pascoe. This is my colleague, and we are going to be doing one of the open discussions for our sexual health open discussion topics, and we are going to be doing the women's roundtable. And obviously, it's titled "Let's Talk About Sex After 50." So, I want you all to let me know if you knew that today was World Menopause Day. Did anyone here? You knew? You also knew? Great. I'm kind of impressed because I thought that no one would put their hands up. But yes, so today, hold on, because I'm a grandma with, okay, there we go. So today is World Menopause Day, the 18th of October. Now, this is exactly why we wanted to do this presentation, because of course, we're not that many people in the session today, but only 2 people put their hands up. So we really wanted to do something that, although there's not a lot of people here after 50, we're all quite young, we wanted to do something that was relevant to today. And this is why we picked this topic for World Menopause Day. Okay, so we're going to start off with something very simple. What is menopause? So I know a lot of people here might still be in the very early years of their medical education. Some people here might not even be in medical school. So I'm going to keep it very, very simple and not go into any technicalities. It is the body's natural reboot or reset button. It is basically a transition from fertile years of being able to have a child to non-fertile years and not being able to have a child. So it's just the body clicking the reset button.
So, think about it. After 45, your body is transitioning. Yes, ovarian function declines, leading to lower estrogen and progesterone. Your periods stop. This is biology, but this is not a disease, and it is certainly not a command to close your door on intimacy, pleasure, or your identity as a sexual being.
Oh, sorry.
Yeah. This matters because sexual health isn't just about sex. It's about intimacy, comfort, confidence, and of course, overall well-being. So,
do I change it again?
Yes. So the question isn't if sex changes, but how it changes. And most importantly, so what? What can we do about it? Let's talk about the how for a moment. Lower estrogen can lead to vaginal dryness and irritation, making sex uncomfortable or even painful. Lower androgens can mean a quieter libido, a lower volume of your sex drive, and reduced sensitivity.
So I'm going to ask a vague question. How do these changes that Katerina talked about, how do they affect how I feel about myself sexually? So obviously it's one thing having changes in my body, but it's another thing how I react to these changes. So I'm going to go through some common myths rather than asking you guys to answer this for me. And that is, number 1, your sex life is over after menopause. Obviously, this is not the case because although, like I said before, our body changes, this doesn't mean that how we feel about sex or how we feel as a person having sex will also change. Yes, our libido might lower or things might be a little bit more uncomfortable, but that does not mean that it completely eliminates the need for sex. Number 2, loss of desire is inevitable and untreatable. This is not true at all because although we did give you guys some facts about what happens to women after they've hit menopause, this is not one size fits all. Not all women will go through this. Some women might experience it much more strongly. Other women might not have absolutely any effects, either to the dryness or irritation that they feel in the vagina or to their libido changes. So it really depends on the woman. But even if someone loses their desire and has a decreased libido, this does not mean that it's untreatable or that there's nothing that can be done about this. And lastly, it's supposed to be painful. You just have to endure it. This is, again, really false. I would like to think that in 2025, we've really established in medicine, not only in just gynecology, but I think also in just general aspects of sexual health, So it is not just supposed to be painful. This is not something that women have to endure. This is just something that they have to work around. So, stigma and societal pressure, because unfortunately, if it was so easy to just tell a woman, okay, but you should just feel okay now, like we'll help you. It's not just that. As doctors, you have to understand that even if you treat all these symptoms, everything that a woman will endure after her sex life changes when she's hit menopause, that does not mean that you can completely eradicate the societal response to that, because she might have someone like her mother-in-law, for example, or her friends tell her older women shouldn't be sexual, or they're not sexual, or it's gross or disturbing that an older woman wants to have sex with her husband, for example. There's also changes in a way a woman can see her body image, or her self-image. Now, this doesn't mean that these changes reflect how she's going to have sex. It just means that she has to navigate herself differently. She has to navigate the way she feels about things differently. And then obviously relationship adjustments, because again, a woman comes in to your clinic, she's asking for help regarding all these changes that she's going through during menopause. Oh, doctor, like I'm having a very hard time having sex with my husband. It's ruining my marriage. He's pressuring me. He's telling me that he's going to leave me. Like these are things that are they're not mutually exclusive. They can happen at the same time. So myths equal silence, because people are not educated that these are myths and not reality. And silence leads to unmet needs. So this is why you might have a woman that wants to get help. She knows that something's going on, but because she feels pressured from society, family, whatever, she tries to seek that help, but even when she does, her needs are unmet. And in this case, we're not talking about sexual needs, we're talking about actual physical, physiological needs. Because even if a woman is not having sex, these problems might affect other areas of her life as well.
But here's a more empowering part. The part where we as future doctors need to champion. This is not a hopeless situation. We have an entire toolkit to help women reclaim their bodies and their pleasure. For medical options like local therapy, systemic hormone therapy, and VVA and not spray, and testosterone therapy. For libido, to simple, more powerful tools like lubricants and moisturizers. But perhaps the most powerful tool isn't found in a prescription bottle. It's between communication between your partner and your doctor. Communication with your partner about shifting the goal from a narrow focus on penetrative intercourse to a broader, more fulfilling definition of intimacy that includes comfort, connection, and pleasure. Communication with your doctor, breaking that silence and saying, this matters. Let's find a solution. And this is where we want to turn this all over to you, because this isn't just a presentation. It's a discussion that we all need to be a part of.
So let's talk. Firstly, what myths do you think are most damaging about sex after menopause? Would anyone like to try to put yourself in the shell of a woman that's after 50 years old? Would anyone like to help answer this question? Maria?
I think it's mostly societal judgments, especially because usually, if not all, women after menopause are usually mothers. And if they're not, this is a completely different discussion, but like, because they are mothers, they are expected to be mothers their entire lives after having a child, which I don't think is true. Because they're people and they're women, and they have the right to have sex after menopause and before menopause. So it's something that is very damaging to their ego, first of all, body-wise, and as mentioned before. And it's also, I feel like it's the judgment of society can impair mental health.
So, okay, I'll jump in. For me, the most damaging myth is the idea that your sex life is over. It's so final and so absolute. It tells women that a huge part of their humanity, their capacity for intimacy and pleasure, has an expiration date. Not only is this untrue, it's also unfair and cruel.
because it makes women feel like there's something wrong with them for still wanting and enjoying sex.
So I think this is the most important question for us that are going to be physicians at some point, hopefully in the near future. But as future doctors, how can we start these conversations sensitively, understanding that our patients have multifaceted reasons as to why their sex life has changed? It is not just about the physical changes. It could be, like Maria said, societal pressure. It could be the changes in their relationship. It could be their changes with how they view themselves in the mirror. So how can we as doctors navigate these conversations? Would anyone want to? Maybe a man? No? Well, should I? Yeah. I think that it's very important, regardless of if you are a man, a male doctor, or a female doctor. It's important to understand that this is not just a physical thing. I know a lot of doctors think that patients will come in, you will treat their physical ailment, and they'll go on their merry way, and the next patient will come in, and etc., etc. But I think it's important for this instance to understand that just curing a woman's physical problems regarding sex after menopause does not mean that you are completely eradicating the problem that she came to you for. She is coming to you for much more than you taking away her physical problems. She is coming for you to help guide her in how to navigate not just the physicals, because it's just one thing prescribing her medicine or giving her an option for a treatment. You have to guide her in how she's going to navigate the rest of her life this way, because who are we as doctors to say that patients are going to stop having sex when they turn 80 or 90 years old? Like, that's not possible for us to know. So we have to make sure that they understand that this is their new life now. This is how their body is adapting. This is a big change, and they have to be able to navigate that change, not just physically, but also with how they view sex. So maybe a woman is concerned about how she has a very low libido and she never wants to initiate sex with her husband, and her husband is really disappointed and is considering getting a divorce or anything. We don't have to go to such extremes, but I'm just giving you an example. You have to be able to explain to her ways that it's not just her fault. There's two people in a marriage. Like, I'm just giving examples, but that I feel it's important to understand as doctors that it's not just physical. I think that's my.
I think it's all about normalization and open-ended questions. Instead of waiting for a patient to bring it up, we can move it into our review system, something like many women your age are going through menopause, we are experiencing dryness and changes in their sexual health, like a shift of desire. And we should say, I asked all of my patients this question: how have things been for you? This makes it a routine medical topic, not a shameful secret. Makes it clinical, not personal, right?
I actually really like that, because I just started my 4th year. I just started my clinical rotations, and I realized that what I was taught in med school, which is you used to take history, you don't. A lot of the doctors I see don't ask about sex life, which is part of social history. And okay, maybe you think that I've seen a lot of older patients. Most of my clinical rotations are things like cardiology, pneumonology, and we usually see older patients. But still, I feel like this is not something I've seen a lot of doctors incorporate into their history. Just asking a basic, hey, like you said, how's your sex life? I know it sounds gauche, but still, I think it's a great point. It's normal. Yeah, it's normal. It's normal, and I think it's not normal enough, if that makes sense. And then our last question for you is, what do you think the main barriers here apply? Patients, providers, or society? Think about it. Yeah.
No, it's the society, really. Just because I feel like it's not experience and community, and people might not want to bring it up personally to physicians unless it's brought up by a doctor.
Yeah.
So I think that's the main barrier, but then also the providers should allow time to talk about the subject, even if patients cannot bring it up personally.
Yeah, that's what I wanted to say. I think it's all three. Like, that's my personal opinion. I genuinely think it's all three. I think every single thing here, patients, providers, and society are all not at fault, but I will say that there's areas for improvements in every aspect.
Well, society creates a stigma that silences patients, then when the patient comes in and all of a sudden they master the courage and they might meet a provider who is rushed, even uninformed or even uncomfortable. This just reinforces the silence, you know? And I think also one without addressing the other.
Doctors aren't immune to the societal stigma. So just because, you know, because we're kind of making providers or doctors different to society, but you have to understand doctors are a part of our society. They're human beings. So I think they're not immune to having societal pressures. No. I personally have met many doctors which have many difference of opinions. You know, not all of them are open-minded. So I just hope that we can become open-minded.
So to wrap up, let's carry these three messages forward. Sexual health is an integral part of overall well-being at every age, and it deserves our attention and care. Multiple effective supports do exist, from medical to hormonal treatments, and of course psychological and relational tools. No one just has to endure it. And always remember, communication between your partner is the main key. Communication is the first and the last. And most importantly, menopause is not the end of your sexuality. Menopause is a new chapter. Sex changes rhythm, and it can be a chapter filled with comfort, confidence, and connection. So let's be the generation of doctors that help women of all ages reclaim it. Thank you. Thank you for your time.
So we're going to move on to our next presentation for sexual health, and this is for men now. So I'd like to welcome to the stage again, Katarina and her colleague, Yana.
Well, good afternoon again. I am Ekaterina, as we know. And this is Ioannis Malafefis. Today we are going to talk about a topic that many people talk about, whisper about, laugh about, and some avoid completely. The title is Let's Talk About Sex After 50 in Men. And as we said again, this is a discussion. It's not a lecture that you listen from your professors or anything. So discuss, you know? We are not going to talk about the sex that magazines glamorize about, but the real biological experience that men go through as they age. We've always been told that a good age to start having sex is at 17, but they never told me when to stop.
Who told you that?
You didn't have the sex talk, did you?
No, I figured it on my own.
It shows.
Whatever. Do you think sexuality ends at 50?
I stole this, I'm sorry.
So be honest, before today, how many of you have heard the term andropause again? Do you know what it is? Do you know what andropause is? Okay, today we will change that, I promise. Many people mistakenly call it the male menopause. It changes that. While women have a clear biological signal, for men it's more of a slow, gradual slope.
The more accurate term is late onset hypogonadism. In simple terms, it's an age-related decline in testosterone and some other hormones. Usually begins by the age of 40 to 50. And while the textbooks talk about hormones and testicles, let's be honest. What really worries the patients is how it affects their daily lives, their energy, and of course, their sex life. This matters because sexual health isn't just about sex. It's about intimacy, confidence, and overall well-being. So, how do you think andropause changes sex? Feel free to answer. Oh, okay. We'll answer.
Let's see, plus confidence.
Okay, we'll answer this question. Now, let's get clinical, but let's also be real.
Well, it's not just one thing that changes. It's a whole constellation of symptoms. Physically, here's what we often see. Lower energy, lower libido, mood swings, muscle loss, weight gain, decreased bone density, hot flashes. Yes, even men can get them too. Insomnia, and of course, erectile dysfunction. These are the most obvious changes for men and men. Talking about vascular and hormonal changes that they need. It may take longer to get an erection, it might be less firm, require more direct stimulation, and ejaculation volume decreases. Erectile dysfunction is often a symptom of cardiovascular disease. So basically, if the engine doesn't start, you have to check the oils. The machinery still works, it doesn't work like it did at 25.
Then we have the psychological symptoms, irritability,
These are phantom.
brain fog, low motivation,
Only Greeks know this.
Yeah.
It's only Greeks know that.
relationship and self-image issues. But here's the good news. Many couples actually report a greater sexual satisfaction later in life. And why? Because sex shifts from being about performance to being about intimacy. And that's something medicine alone will not prescribe. So when it comes to the treatment, testosterone replacement therapy is the headline actor. It improves energy, mood, libido, muscle mass, and bone density. But there are some risks: cardiovascular events, prostate complications, and polycythemia. Long-term safety is still being studied. And of course, we do have the PDE5 inhibitors for erectile dysfunction. You've probably heard about them before as Viagra. You know, the blue pill.
Now, let's dive into a case. I want you to picture a 38-year-old man. He is tired, his libido is in the basement, and he and his partner haven't been able to conceive in over a year. His past medical history isn't concerning. He isn't taking any relevant medications. He is not a smoker, but he doesn't exercise much. These were his results after his examination. His body mass index was slightly overweight. His testicular size was normal. He had no gynecomastia or signs of hypogonadism. His labs show low testosterone and abnormal sperm count, which suggests some fertility and poor motility. Everything else was normal. Now, here's the question. On this particular patient, do we start testosterone therapy? Think about it. What does extra testosterone from the outside do? What do you think? You know? Do you have any ideas? Okay. His body's natural signals to make both testosterone and sperm get shut off. It's like pressing the pause button on his fertility. So for this patient who wants to be a father, is testosterone therapy the correct choice? Obviously not.
The study compared two paths. The first approach is conventional, like the classic playbook. It included lifestyle changes, like diet and exercise. Safe and cheap, but after a year and a half, nothing had really changed. His fatigue and libido were still a problem. The second approach was integrative. This is where it gets interesting. Acupuncture to reduce stress and potentially improve gonadal function, and targeted antimicrobial protocol for H. pylori. The results, the integrative approach won by a mile. Pretty impressive, right? Testosterone, motility, GI, stress, libido, they all improved. Of course, it's not magic. It's multifactorial, time intensive, and you have to stay consistent. The takeaway, sometimes the most effective medicine isn't just found in a pill. It's in the balance between body, mind, and lifestyle.
Now, let's talk. Here's some questions for you. As future doctors, how do we start these conversations sensitively? We talked about it earlier, yes.
And also depends on the place where like the history is being taken, the position the patient is in, because many times like we have history taking being performed inside the emergency room or in even at the general practice, but somewhere where it's very crowded, so you like the patient is gonna feel uncomfortable.
Yes, exactly.
So it's also a matter of having the correct place, ensuring privacy and also ensuring that the patient feels comfortable, because even sometimes the doctors tend to sit in front of the patient as if like they are the lawyer or as if they are.
Yes, exactly. They feel like they're being judged.
Yeah. The doctor should even have a practice shaped manner that the patient is gonna feel comfortable, even if you're gonna put a chair next to the patient instead of having a desk, which is a considered psychological barrier and having the patient up. So it's kind of also depends on the placement, privacy, and how the patient's gonna feel. So it's very important to
Yes, exactly.
take this on.
Yes, thank you. Yes. You wanted to say something? Oh, it's in my class. Okay.
I'd say that we have to normalize it.
Start with general well-being questions before moving on to sexual health.
Ask the patient, many your age experience changes in energy, mood, or sexual function due to hormone levels. Is any of that on your radar? Make it clinical, not personal.
Create a comfortable environment and use empathetic language.
Avoid assumptions and ensure confidentiality. And do you think men talk about this openly? Or do they hide it? And why?
Any ideas?
They definitely hide.
Come on, we talked about this earlier.
They definitely hide it.
Yes.
Okay, yes, they hide it, of course they do. Probably because of stigma, shame, or even fear of being seen as less masculine.
Why is that?
Well, probably lack of awareness that andropause is a medical condition.
It's our job to educate them on this matter and create a safe space for them to be honest.
Now, and this leads us perfectly to our next question on the screen. What role does communication between partners play in maintaining sexual satisfaction?
The biggest role.
Yes, exactly.
Really important. So think about it. Andropause doesn't just happen to one person in a relationship. It affects both partners.
When a man starts feeling insecure about his erectile changes, he withdraws from his partner, and his partner misunderstands it and takes it personally, right? What else would she do? She now starts thinking that he is no longer attracted to her, which is obviously not true.
But by communicating with his partner can completely change the game. It's no longer a performance issue, but a team project. It's about saying, this is a change we're facing together. How can we adapt and stay connected? So one of the biggest myths, your sex life is over after andropause. Loss of desire is inevitable and untreatable. These are lies. Sexuality does not end at 50. It evolves. It changes the rhythm. It becomes more about intimacy and connection and less about performance. It's not about extending function. It's about redefining satisfaction. So what? Sexual health does not end after 50. And our role is to ensure that our behaviors, that everything that is happening is normal. And there are many solutions to that. There's our references. Thank you very much.
Sorry, I have just a small point. In your first slides, you mentioned that for the case report, the particular patient did not have hypogonadism.
No.
However, in your labs that you showed, he showed low testosterone. And I'm just letting you guys know that in case you missed it, hypogonadism, one of the clinical criteria is low testosterone. So it's considered hypoandrogen. So that's just to know in case you missed it in the literature.
Okay, thank you.
Thank you.
Thank you.
Yeah.
So we're gonna have our workshop now for advanced life support. I encourage you all to stay because advanced life support is something that all doctors need to know. Something very, very important, okay? And just to inform you, advanced life support, there are examinations going on. So if anyone is interested in taking the ALS exam, the advanced life support exam, please do send me a message and I will give you information on how to ask for participating in the exam. You will again do a course analytically that will explain the whole thing about advanced life support, the whole theory, and also in practice. So you will have also a training session and the cost is around 200 to 300 euros. Okay. So if any one of you is interested, please do send an email to simetres@gmail.com, okay, in order to get some information. So advanced life support. Let us start. So as a person who has been working as an assistant nurse in the intensive care unit for the past 2 years, it's something that I see daily. So I'm gonna share this experience and teach you the theory of what is advanced life support. In hospital resuscitation, that's the first word that comes up. We have a patient in a critical situation in hospital. What do we do? Let's say you are a resident doctor who's on a night shift at the emergency room, at the ward, at the internal medicine ward, anyway. As a doctor, you are expected to be able to help the patient who's critical and to be able to save the patient's life, okay? So, the hospital resuscitation has this algorithm, which we're going to go through together, okay? We are going to be called, there is a sick patient who collapsed. The first thing you're going to do, you're going to ask for help. You cannot resuscitate a patient on your own, okay? You need a team of nurses, assistant nurses, you need a team of doctors, okay, to help you. You cannot resuscitate the patient alone. So you're gonna call for help, and then you're gonna assess the patient at the same time. So you're gonna go run towards the patient, and at the same time shout for help. Okay?
Do you want to be the patient?
Yeah.
Do you want me to be the patient?
Okay. You have to run, and at the same time, you're gonna shout for help. It's called the blue code. In Cyprus, we don't use the blue code. In the United States, they have a blue code. So you're gonna hear the whole hospital in the speakers saying blue code, which means that there's a collapsed patient. So the next thing is you're gonna check for signs of life. If you have signs of life, which signs of life? What are signs of life? You're gonna, if the patient's lying there, you're gonna bring your face close to the face of the patient to see if the patient's breathing. Okay, so we're gonna hear, feel that the patient's breathing. If the patient's not breathing, then it means there are no signs of life. You're gonna check the pulse after breathing. Do we check pulse from the radial artery? Hands up. Who agrees to check pulse from the radial artery? Easiest way, radial artery.
You can.
Why do we not check from the radial artery? Let's formulate a question like this. Why not check from the radial artery?
There could be poor perfusion, there could be trauma.
Correct. In a collapsed patient, we expect blood pressure to be low. Okay? We expect the patient not to be in the most fit situation. So the organism is not gonna send blood to the upper limbs. Okay? It's not the best architecture in a collapsed patient. We're gonna have low blood pressure, we're gonna have blood vessels that are gonna contract, okay? So we're gonna have contractions of blood vessels, so it's never the best place to check. The two places we're gonna check is the carotids, okay? The carotids, which are here, and the femoral. The femoral left. So, if there is no pulse, it means cardiac arrest. It means the patient is in cardiac arrest. If the patient does not have a current or femoral pulse, it's cardiac arrest. So, again, you're going to call the resuscitation team to come. One person is going to take the lead to lead the whole situation. We're going to start with CPR, defibrillation, and ALS. Otherwise, if you're not going to have cardiac arrest and you have a collapsed patient, then you use the ABCD protocol, which we're going to see. So CPR, most of you from basic life support, BLS, know what CPR is. How many of you have done a course in BLS, basic life support? CPR, how many of you know how to perform the CPR? CPR? No. So I'm not gonna take much time on CPR. You take this stance, the hands need to be straight, okay? When you're doing CPR, you never do CPR like this. The hands need to be straight. And it's at a rate of 100 to 120 beats per minute. You do 30 chest compressions, followed by 2 breaths with an ambu mask. You know what's an ambu mask? Everyone? Ambu mask? Right. Okay. So, the first thing you have to do once you are doing the CPR, not after, once you are doing the CPR, first procedure after, because the first thing which is important to collapse patient without a pulse CPR is to manage the air. To manage the airway, we have different ways. You can use an oropharyngeal airway, which you can see here, oropharyngeal, ancient Greek word for the mouth, oropharyngeal airway. So it's inserted in the opposite direction of the oropharynx. So if the oropharynx is like this, you insert the mask like this, and then you turn it. Okay, you can use a nasopharyngeal airway as well. You place the ambu mask with this gesture, which is called CNE, which means you hold the ambu mask in a C position with your fingers, and with an E position, you lift the chin up, okay? So that the airway is open, and you can ventilate the patient. Okay? And at the rate of 10 breaths per minute, we give ventilation. Or you will use the other protocol, the BLS protocol. Use the BLS protocol. What does it say? 30 compressions, 2 breaths, or you're going to give at 10 breaths per minute if you've got someone who can give cost with the ambulance. Okay? Next, you have to connect a defibrillator. Okay? Always you connect a defibrillator. Always. Although we may not use it. Why? Because we need to assess the rhythm. If you are in the ICU, you're going to see the rhythm because the patient is under continuous monitoring in the intensive care. But in the ward, the patient is not going to be under continuous monitoring. So you're going to put these 2 patches very easily, one up, one down. Okay? We prefer the one up to be right and the one down to be left. So it's at the apex of the heart. Okay? At the apex of the heart. We connect to the monitor, we assess the rhythm, we don't shock, we don't give a shock to our patients. You have to first assess rhythm, okay? So, you have to assess the rhythm and see if you have a shockable or a non-shockable rhythm. Shockable rhythms of cardiac arrest are pulseless ventricular tachycardia, or VT, what we call pulseless VT, which pulseless VT has this form. So you have like shark fins. That's how we describe it, okay? They look like the fins of a shark, right? If you have shark fins, it means you have VT. And if you don't have a pulse, which when you have cardiac arrest, you don't have a pulse, it's considered pulseless VT. It's always rhythmic, okay? So you don't have an arrhythmia here. It's at the same rhythm the shark fins. And that's how you recognize a pulseless VT. And a ventricular fibrillation, VF, is when you see all this line going like someone's scribbling with a pencil. It's like a scribble, okay? So it doesn't have a rhythm, it doesn't have anything. It can go up, down, it can be flat, okay? That's what's called a ventricular fibrillation. So it's like chaotic activity of the ventricles. Next, we have the pulseless electric activity, which this is a non-shockable rhythm. You don't have a pulse, okay? And the heart is working, as you can see. It's giving a normal ECG. That's a normal ECG, okay? But you don't have a pulse. Here, giving a shock is not going to help. Why? Because the way the heart is conducting the electrical signals is normal, right? So you don't need to give a shock here. It's logical. But as a trainee in ALS, you should know to distinguish the types of shocks, which are shockable, which are non-shockable. And next we have asystole, the famous flat line, which we see all over the Hollywood movies, right? Which is an asystole, a flat line. The heart's not working, a shock is not going to help regenerate signals, electric signals. So here you don't need to give a shock. Okay, so let's again see the whole protocol. Absent breathing, absent pulse, you attach the defibrillator, CPR at the rhythm of 30 to 2, BLS protocol, you assess the rhythm, okay? If it's shockable, you give one shock, okay? You immediately give one shock, and then immediately resume the chest compressions for 2 minutes, again assessing the rhythm. So every 2 minutes, you have to hold the CPR process, you hold CPR, process the rhythm. If you have a return of the circulation, so you have a pulse, or you get blood pressure on the monitor, it means it's okay, you have blood pressure, you don't need to continue CPR. If it's a non-shockable, like asystole or pulseless electrical activity, you just resume the chest compressions. And again, you have to assess rhythm. Why? Because let's say an asystole after CPR can turn into a pulseless VT. It's still in cardiac arrest, the patient, so it's pulseless VT, it's cardiac arrest, but it's no more asystole. So it's important every 2 minutes to assess the rhythm, to hold CPR and assess rhythm, okay? Next is the drug administrations. You have to give intravenous access, okay? I prefer you give with 16G, the gray cannula, okay? So afterwards you can have rapid infusion of fluids. So if you cannot even find a vein at that time in the patient, you just give intraosseous, okay? Give intraosseous injections. Next, you have the vasopressor tracts. The vasopressor tracts is adrenaline, okay? A very famous hormone that's created by the adrenal glands, adrenaline. 1 milligram IV as soon as possible. So you start adrenaline as soon as possible in someone who's with a non-shockable rhythm, because it can create a shock to the heart instead of the electric shock. If you have a shockable rhythm, you're going to give the adrenaline after the 3rd shock. Okay? After the 3rd shock, this is important to know when we give adrenaline. Then you repeat adrenaline every 3 to 5 minutes. So after the 3rd shock, and then every 3 to 5 minutes. For someone who has a non-shockable rhythm, ASAP, adrenaline, and then every 3 to 5 minutes, whilst CPR continues. Then you have the antiarrhythmic drugs, amiodarone for adult patients who have shockable rhythms after 3 shocks. So you know that you're going to give the medications together after the 3rd shock. Adrenaline after the 3rd shock, amiodarone 300. Okay? Then you give a further dose of amiodarone in the patient who is shockable driven after 5 shocks. In a not shockable, you don't need to give amiodarone because it's again a cardioversion drug. It's not going to help. You don't need cardioversion in someone with PEA parasystole. Last, we have lidocaine, which is when amiodarone is not available for those who are in like a remote area and we don't have access to amiodarone. Lidocaine, which is a topical anesthetic, has the same effect, 100 milligram IV, okay, with the same instructions we're gonna administer after the 3rd shot. And then you have the thrombolytic drugs. You are gonna consider if you suspect a pulmonary emboli or you suspect a myocardial infarction, okay? And then mine. Next is considering intubation. Do I intubate the patient when I do CPR? It's not important to intubate the patient, except if it's necessary. So the reason why the person has a cardiac arrest was a cardiorespiratory arrest, so you need to intubate. Okay? If you want to intubate the patient, you need to aim for less than a 5-second interruption in chest compressions to intubate, so you need an anesthesiologist, okay? Anesthesiologist or someone specialized in intensive care medicine. You are not going to intubate, even if you are a cardiac surgeon, if you are a, I don't know, neurosurgeon, you're not allowed to intubate. Work for the anesthesiologist, okay, who can do the intubation because it's his or her job to do less than 5 seconds. Otherwise, we don't do, because you can't intubate the patient while he's under CPR and he's going up and down. So you have to resume CPR for some time in order to be able to intubate the patient, right? So you're not going to intubate if you don't have a professional. Otherwise, you can insert a laryngeal mask, laryngeal mask, otherwise known as an eye gel, okay? And give ventilation at the rate of 10 per minute, either connected to the ventilator or using the ambu mask manual. Okay? Any questions until here? Next, we have the reversible causes of cardiac arrest. The well-known 4 H's and 4 T's. What are the 4 H's and 4 T's? It's very important for every doctor to know. Okay? The 4 H's and the 4 T's are causes that can cause cardiac arrest, and you can reverse these causes, okay? So you can do something to remove this cause, and so the patient is going to be away from the danger of cardiac arrest whilst you are doing CPR. So as you are doing CPR, you're going to assess these things as well. The 4 H's are hypoxia, as we said, cardiorespiratory arrest, hypoxia, no oxygen, hypovolemia, low blood volume, usually after some form of heavy hemorrhage, heavy bleeding. Then you have hypothermia, very common in military personnel, in special forces, to come with cardiac arrest because of hypothermia, because they took them to what you call a military drill in the sea during winter time. Especially consider, let's say, in a high geographic country near the North Pole, like Norway, let's say, like Sweden, and they take their military personnel during the winter, so it's very common to hypothermia as a cause of cardiac arrest. Then you've got hyperkalemia. Hyperkalemia is more a cause of cardiac arrest rather than hypokalemia, and there are specific protocols for each of these two, which we are not going to explore. The 4 T's are tension pneumothorax, usually post-injury, which means air is flowing into the cavity that holds the lungs, okay? Into the pleural cavity, So you have to have flow to the pleural cavity, and the pleural cavity is pushing the lungs, causing respiratory arrest. Then you've got the tamponade. The tamponade is when the heart is full of fluid, pericardial sac, and it's pushing the heart. This usually happens post-heart surgery, post-trauma, and in severe cases of pericarditis. Okay? Then you've got the toxins. So some toxin overdose of a medication or something, let's say of paracetamol, can cause cardiac arrest. And then thromboembolism, which we said it's myocardial infarction and pulmonary embolus, right? Okay, so these are the 4 H's and 4 T's. Let's move on. We don't have a lot of time. I'm going to take like another 10 minutes just to sum up. Okay, now, let's say the patient is resuscitated, or the patient was not in cardiac arrest, as we said in the beginning, right? It's a collapsed patient, but he has a pulse in the carotid or has a pulse femoral, right? So, in this case, we have another protocol, which is called the ABCDE protocol. What's the ABCDE protocol? Is airway, breathing, circulation, disability, exposure. You need to know this. Airway, is the airway open? Okay. Breathing. How is the respiratory condition of the patient? Circulation. How is the cardiovascular system working? Any other form of disability, neurological or induced by hypoglycemia, and the exposures to trauma. Okay? So, to assess the airway is very easy. If the patient can talk, the airway is okay. Even if the patient is making a sound without making scripted noises, it means it's okay. Right? So you just go to the patient, you say, let's say, Mr. Yorgos, Mr. Yorgos. And if the patient can respond, say, even, it's okay. The airway is open. So you don't need to, because if you have a problem with the airway, you have to put either an adjunct or an oropharyngeal airway somehow to open the airway. Okay? Then you've got the breathing. For breathing, you have to see respiration rate quickly. You can take it with your analog watch, with a good old even analog watch that I'm wearing because I'm not really onto smart watches. You can measure in 1 minute how many breaths the patient is taking. Okay? Then you've got the SpO2. You're going to connect it to a probe to see oxygen saturation, and you're going to listen to both lungs. If you have, let's say, no breathing sounds in one lung, it means the lung is collapsed, most probably tertiary pneumothorax. Circulation, you're going to do an ECG, always do an ECG, check blood pressure, put IV axis. Okay? The way I like to say is you start from here. Heart, ECG, blood pressure, IV axis, and then capillary refill time. All of you know the capillary refill time. So, easy protocol for the C. D is the disability. You're going to do a neurological assessment on the patient. You're going to check the temperature of the patient, the body temperature, and you're going to check the blood sugar. And E is just a head-to-toe quick examination to see if there is trauma or any exposure to any kind of bleeding, trauma, or something that is putting the patient's life into danger. Okay? With the ABCDs? So let's go to our first scenario. I want you guys to participate in the scenarios. First scenario, you're called at the ICU for a patient who shows the following rhythm. So you're at the ICU, the nurse calls you, and we have this rhythm. SpO2 95%, and blood pressure 105 to 75. Patient is not intubated. What steps do you need to take? Someone. Yes, Mrs. Hadka. You call for help, right? And then what do you do here? call code blur, this is a shockable rhythm. Do you even need to do a CPR here?
It's a shockable rhythm.
It's a shockable rhythm, but do we need to do a CPR here? It's a trick question.
Pulse is not found, you always start CPR.
You can't find a pulse, but you have blood pressure. If you have blood pressure, you don't need to do it. So it was just a trick question. Okay? You can't find the pulse. Why? The nurse was kind of, let's say, scared at that time. It's a human being. You will not find the pulse. If the nurse is gonna, it's very common. For the doctor, I have blood pressure. You don't need to do CPR. He has blood pressure. It means it's okay. So here, you don't need to do CPR. You just need to do cardioversion. Okay? So you're gonna give a meal. Or you're gonna give a shot on. Only cardioversion. Scenario 2, 70-year-old patient, emergency room, following presentations. Lethargy. He's found fainted by his caretaker in the kitchen. The caretaker brings him to the emergency room. The caretaker refers that patient flu in the past 15 days. He didn't go to the doctor. He treated himself with home remedies. Now he's here with lethargy, which means he's unresponsive. So, what kind of assessment are we going to take?
The ABCD.
Very good. ABCD assessment. Okay. Airway. Patient can say air noises. So it's like he's fully disoriented, but can make some noises. What does this imply for the airway? He's breathing. You're gonna go immediately to the next step. It's ALS. You have to be quick. Breathing. SpO2 91. Patient is cyanotic on his ears. What does that mean?
Supplementary oxygen.
You just need to give supplementary oxygen. Why? Because SpO2 is above 90. If it's above 90, you don't need to worry to intubate the patient or something. Just going to give supplementary oxygen at 5 liters, okay? Patient is cyanotic, it means somehow he's not receiving enough oxygen. It's a sign of hypoxia, okay? So you have to give oxygen to help the patient. Next, circulation. Heart rate, 125 beats per minute. What does that mean? Tachycardia, right. Blood pressure, 85/59. Hypotension, it's less than 90/6. When it's less than 90/60, it's hypotension. So you give rapid infusion of fluids, which means 500 ml normal saline, okay? 500 ml normal saline in 15 minutes. 500 ml normal saline in 15 minutes. You're gonna put it to the full. So as you have the simple set of giving, we're just gonna put it into full, 500 ml of normal saline. Capillary refill time 3 seconds is more than 2 seconds, it must be less. So we have a problem with the perfusion. We take blood gases always, okay? As we insert a catheter to a cannula, to give medication, gonna turn the hand and take also blood gas. It's important. Blood gases give a lot of information. Some people say, blood gases are no, they are very important, okay? They can give a lot of information at that time. So we have pH 7.2, lactates 5 millimole per liter. Lactates should be below 2. Lactates above 2 means hypoperfusion of tissues. Means not enough oxygen is going to the tissues. We have anaerobic respiration. Due to anaerobic respiration, we are producing lactic acid, right? So this is causing me metabolic acidosis. You agree? Okay, very good. And the PO2 is slightly decreased, and this we knew from the SpO2, the decreased. Next, disability. Glucose 120. Is it okay? Glucose 120, it's okay?
Yeah.
Very good, it's okay. Temperature 39.5. Is it good temperature?
Fever.
It's fever. Do I give paracetamol? Always. To the patient? No. You're gonna drop the temperature, just giving some isopressions at that moment. To be quick, okay? You're not gonna think of giving paracetamol because until paracetamol acts, the patient might have too much temperature. which might affect his neurological system. And his pupil reaction is normal, stable. And we have some bruisings on his body. So, why we set this scenario is for this fact. For someone who's doing ALS, especially you who are medical students, okay, you've been taught to first think of diagnosis. So you're on top of an emergency patient, and you think, oh, what's wrong with that patient? I've read that thing in that lesson, I've read that thing in that book, that thing in that review paper. You're not gonna think like that at that time. The patient's in danger, okay? The first thing is stabilize the patient. We don't care what's wrong with the patient, okay? Except the 4 H's and the 4 T's, which we said in cardiac arrest, we don't care. First, you stabilize the patient. That's a rule of thumb for anyone working in the intensive care unit or in the emergency room. Always stabilize the patient and then think of the diagnosis. So here, extra fact, I think you could have guessed that we are talking about septic shock in that patient, hypotension, fever, right? Lactates, bruising, signs of sepsis. Possibly by a pneumonia because he had a flu which was left untreated. He didn't go to the doctor. He should have been followed up by a doctor to take antibiotics, to receive care, but he didn't. He was home remedies, a big mistake. We always need to refer to the doctor, even if we are like doctors ourselves. We need to refer to the doctor because even a simple flu can lead, even I now have a post-airway irritation of my lungs. Until yesterday, I was coughing all the day because I had a flu and I didn't go to the doctor. Okay, it's very important. So you should be also placed on empiric antibiotic therapy to treat the sepsis. But at ALS level, we don't care about the sepsis. We care first to stabilize, and then you're going to think, okay, this is sepsis probably, so I'm making antibiotics. Any questions? Any at all? Information regarding the exam, you can send an email, or you can send me, if you have my number on WhatsApp, a personal message, okay, to see.
Okay, so we're gonna move on to our final block of presentations. We only have 4 presentations left. But we're just gonna do a small sound check for our online presenters. So just give us 2 minutes.
Yeah, 5.
5 minutes, okay?
Έδωσα σας 2 pointers about επιστρέψετε και τα 2 pointers στο security.
Οκ, τέλεια.
Guys are listening. For some reason, they put me on this online. This is why we're so late. Okay. Yeah, it's strange. So happy because we do all of our presentations at the end. Oh, sorry about that. We're going on now? Yeah. Just after our session.
إذا بتطلع السم كم يفضل عن فيلمز
Sorry. Can you guys, can you move a bit? Sorry.
This is what I wanted. Why did you why did you do this is so late every single time you guys imagination. I'm so sorry, what kind of it and then it happens again. There's a lot of disgusting it's sweetheart, like these things. It looks like that's not small. Like so they wrap that and they want to start. How old is it 6 years?
I hope I pronounced that correct. I'm so sorry.
I'm currently a medical student at the University of Minnesota. And today we're going to talk about the Todd syndrome. So imagine you're at home, you're peacefully reading the book, and then all of a sudden you see the pages are expanding, the words are shrinking. You feel like your limbs are going long. You feel like the furniture is shrinking, and you might be thinking, "Oh my God, am I hallucinating?" You feel like you're detaching from reality, and you feel like time is passing so slow. So you might be thinking, "Am I hallucinating?" No, you're pretty conscious and communicative, and actually you're experiencing the first symptom of Addison and Mongeron syndrome. And this was actually a case study. So like a 10-year-old actually experienced this. And it was a case study that was conducted by the UNSR. So what is Todd syndrome? So it's basically a neurological disorder in which a patient experiences brief and episodic distortions of visual perception, body schema, and the perception of time. And it often occurs in association with migraine, viral infections, or epidemics.
Okay, so I'm going to briefly talk about the clinical features of Todd syndrome. Now they're categorized into 4 main categories. So we have visual disturbances, we have somatostatic disturbances, we have time and sound disturbances, and extrapersonal misperceptions. Now the most common are the visual disturbances, and they fall into more than one category. I'm going to be mentioning them. So the first one is the micropsia versus macropsia. So patients describe seeing objects as smaller or larger than they actually are. Then we have metamorphosia, and patients describe this category of visual disturbances as twisted or stretched visual appearance of objects in front of them, often described as the glassy appearance. We also have telopsia and pilopsia, which also is described as seeing things further away than they actually are, or closer to them than they actually are. So basically, in telopsia, the chair that's right in front of me appears like it's very far away. And in pilopsia, it's the exact same opposite. So the wall that's right across the room feels like it's very up close. Next up, the second most common category is the somatostatic disturbances. In these type of disturbances, patients describe their body as out of proportion, often linked to maybe larger limbs, shrunken hands, as seen in this picture. And then the next 2 categories are not as common, but they are still worth mentioning. So we have time and sound distortions. Time basically defined as maybe sped up or slowed down in these episodes. And we have sound distortions where patients sometimes cannot hear their own voice, or their voice or other voices appear loud pitched. And for the last one, we have extrapersonal misperceptions, often described as out of body experience. So patients have a sense of derealization, like they're not in the real world, often like maybe like in a dream. So talking more about the episodes themselves, they typically last from seconds to minutes. In some cases, they can be mentioned up to an hour. And full recovery is expected in between these episodes. So they have the episode, they see all these visual disturbances, misperceptions, and then after the episode is done, they go back to normal consciousness. And other associated symptoms include anxiety, fear, and depression. So if you have a look at this table, it's reported cases of specific patients that have been through this. As you guys can tell by the age of onset and age of presentations, it varies from ages. It can go up from 61 to early 20s, and it's prevalent both in male and female sexes. So if you have a look at case number 7, we have a female who describes telopsia, and I quote, "Furniture seems far away, and out of body experience, feel like she is not in her own body, and auditory distortion, unable to hear her own voice." Now, as we mentioned, this is a mix of different types of distortions. We have auditory distortions, visual and extrapersonal misperceptions. Also, if we look at case number 6, We have a male that describes an out-of-body experience, feel like he is outside of his body. Again, this is extrapersonal perceptions, and you guys can read the table. There are different episodes. Every episode is unique. No episode has the same pattern of distortions. As you guys can see, for example, in case number 4, we have derealization. In case number 1, we have visual disturbances. So it's a combination of different patterns of distortions. Thank you. So in this section, I'll be discussing the etiology and the pathophysiology, where I'll be explaining the causes behind this condition and how these causes could lead to the symptoms that we see clinically. So on this slide, we're looking at the major causes and triggers, all of which lead to disturbance in the brain function and activity, contributing to the clinical features seen in Todd syndrome. So to make it easier to understand, we've grouped into 5 major categories. And the first category that we're going to be exploring is the neurological category. So the most frequent cause or trigger under this category is migraine with aura, and other causes and triggers include epilepsy or focal seizures and head trauma or concussions. And another common cause is due to an infection, which is the cause seen earlier in the clinical case presented at the start of this presentation. So such infections are usually due to Epstein-Barr virus, Coxsackie virus, or even influenza virus. And even after the infection clears, there can still be post-infectious inflammation, which continues to irritate the brain and trigger symptoms. So another category of triggers are drug-induced, which occur either due to medication or substances like hallucinogens, such as LSD or cannabis, or even anti-seizure drugs or other psychoactive drugs. And other psychological factors can also play a big role in Todd's syndrome, such as severe stress or anxiety, or even depersonalization disorders, as we mentioned earlier, that the person feels detached from their reality. And of course, finally, the last category of causes and triggers are other or structural triggers, such as brain tumors or lesions, stroke or transient ischemia, or even could be as simple as fever in children. So you're probably wondering, how do all of these causes lead to the disturbances of the brain function and contribute to all of the symptoms that we have explained earlier? And that is why we're going to be explaining the different underlying mechanisms in the next 2 slides. So the first mechanism that occurs during Todd syndrome is cortical dysfunction in visual and somatosensory areas, which is basically abnormal electrical activity in the areas of the brain which are occipital and parietal lobes. Which leads to our perception getting distorted, and that's why we call it like cortical dysfunction. So in the example of migraine, there's the phenomenon of cortical spreading depression, which is a wave of electrical silence that moves across the visual cortex and the parietal cortex. So as this wave passes, it temporarily shuts down the brain's activity in those regions, which in other words, the brain's perception is glitched, and therefore creating the distortions we see in Todd syndrome. Similarly, in focal seizures, there is an abnormal burst of electrical firing that occurs in both the occipital and parietal lobes, and therefore mimics the same effect as the migraine aura. So all of these disturbances lead to the clinical features that we have explained at the beginning of our presentation, which are micropsia or telepsia and telepsy. So now let's look at how temporary changes in the blood flow could also lead to or contribute to the symptoms. This is also known as transient cerebral perfusion changes. So what happens here is that the occipital or the parietal lobes receive either too little or too much of this blood flow for a short period of time. So in the example of migraine, it's met with an increase in blood flow, and then there's a sudden drop in this blood flow, and this is, again, we go back to the same phenomenon called cortical spreading depression. And in this period is where the symptoms start to develop, or all the symptoms they start to occur. And in the case of viral encephalitis, there is the presence of localized swelling or edema, which puts pressures on nearby blood vessels, and therefore this alters the perfusion in those areas, and again leads to temporary dysfunction of the cortex. So these transient or temporary blood flow changes explain why these attacks are short-lived, and they're also temporary and reversible. So once the normal blood flow go back to normal, the affected brain areas that were actually disturbed, they recover and the symptoms fade away.
Now, another mechanism that occurs during TOT syndrome is the thalamocortical network disruption. So the thalamus, basically, and usually, it filters all the sensory information before it reaches the cortex. So in the case of TOT syndrome, it starts to misfire. So for example, after a seizure or like a post-viral irritation, it sends distorted signals to the cortex. So this causes the brain to misinterpret sensation like time, motion, or even body shape. And next, we have the other, we have neuroinflammation or infection, which often link to viral causes, since certain viruses can trigger mild encephalitis or even post-infectious immune reaction. So what happens is the body tries to protect the brain by secreting certain cytokines or antibodies. And this therefore makes the blood-brain barrier more leaky and more permeable. So this increased permeability allows fluid or immune molecules to seep into the surrounding brain tissue, which leads to localized swelling or edema, especially in the occipital or parietal lobes that we mentioned before. So this pressure and inflammation temporarily disrupts how neurons communicate, and that's why patients experience distorted perception of size, distance, and body image. And the last mechanism that undergoes during TOT syndrome is neurotransmitter imbalances, and mainly serotonin, glutamate, and GABA. So serotonin, or mainly the prime example, is during migraine or in migraine aura. There is serotonin levels fluctuate. So first, at the start, there's an increased level of serotonin, which leads to vasoconstriction, and then it drops, which leads to vasodilation and the cortical spreading depression phenomenon that we described before a while. And the other neurotransmitters that are involved in TOT syndrome are glutamate and GABA. Glutamate, which is the excitatory neurotransmitter, and GABA, which is the inhibitory. So in cases of seizures or focal cortical irritation, there is very high levels of glutamate, which is the excitatory, and very low levels of GABA, which is the inhibitory. And therefore, this balance shifts towards the excitation. So there's too much glutamate and too little GABA, which leads to uncontrolled electrical firing, making the neurons hyperactive and misfiring. And therefore, they produce the same distorted sensation.
Diagnosis of TOT disease is quite challenging as it relies on the description of the patient's perceptual distortion. So basically, we get these descriptions during consultation by asking these questions, or during clinical examination, physical examinations, and neurological examinations. And that's not it. It's also challenging because there's no definitive tests. Tests are usually to rule out differential diseases, maybe using neurological imaging, the EEG, which is the electroencephalogram, or the lab results. So let's elaborate more on the clinical investigations and findings over here. First, let's look at the patient history. We first ask if they have any history of migraines or seizure disorders. We see if they have any infections, drug exposures, or sleep deprivation, any presenting symptoms like headaches, nausea, photophobia. And if episodes are short, they don't occur for a few minutes or an hour, and in clear consciousness, it means these all indicate TOT disease. And a characteristic feature could be the preserved insight, meaning that patients are aware that what they perceive is not real and can describe the phenomenon clearly. Moving on to physical examination, we check for fever or systemic illness, especially in children, in order to see if there is a presence of viral infection, which could be a reason for post-viral TOT disease. Another examination could be the neurological one. We check for visual distortions, which are present during TOTs. Otherwise, it could be an ocular disease. We also check for visual fields, eye movements, sensory motor functions, which are normal during TOTs. If sensory or motor functions are abnormal, this could be an indication of strokes or space-occupying lesions in the brain. And finally, we perform a psychological examination, which is the mental status examination, in order to rule out any psychiatric conditions like psychosis or any other. Now let's look at further tests in order to confirm our diagnosis. We start with a brain MRI, which is usually normal during TOT disease.
Any abnormalities could indicate tumors, strokes, or neurological disorders. But sometimes during the brain MRI, there could be transient hyper or hypoperfusion in the brain cortexes, which could indicate episodes of migraine-related thoughts due to altered cerebral blood flow. Another test is the EEG, in order to distinguish the type of the thought disease, whether it's epileptic or migraine-related. We also do screening, serum screening for EBV, influenza, and maybe drugs, if there's any drug substance used, in order to, again, to indicate the cause of the Todd's disease. And finally, sometimes referred to long-term puncture, but this is very rarely used. We only use it in presence of high fever or altered consciousness in order to rule out encephalopathy. Now let's discuss some management points to consider. Management usually, there's no specific medication for Todd's disease. We usually focus on treating the underlying cause and treating the symptoms. So for example, for migraine-associated Todd's, we use prophylactic therapy like beta blockers and calcitonin blockers in order to avoid the recurrences. We use anti-epileptic drugs in presence of epilepsy. We treat the infection in post-viral Todd's disease, and in cases of drug-induced Todd's disease, we discontinue the substance in order for patients to recover. Now let's talk about the prognosis. It's excellent overall. However, episodes usually happen in migraine-related Todd's disease. However, these are mild and transient, and they respond well to prophylaxis. In cases of epileptic Todd's disease, prognosis is improved once you control this.
We want to talk about the Todd syndrome because of the high probability of it being misdiagnosed. So because of the distortion and the distortion of the visual perception, as well as the distortion of the time and many of those things, a lot of people might misdiagnose it as it being an epilepsy or psychiatric disorder. So as a result of that, for us to be able to accurately recognize the Todd syndrome and to diagnose it correctly, in order for us to prevent any unnecessary treatment. Yeah, thank you.
Thank you so much. We are now going to move on to our final three presentations, which are going to be held online. Okay, so I'd like to welcome our first students to the virtual stage, Mr. Andre and Mr. Naren.
Good day, everyone. Just want to make sure that you all are able to hear me.
I can hear you.
Great. So my name is Andre Amkaran. Naran.
Yeah, and I'm Naran Mahadi Singh.
And we are both undergraduate medical students from the Royal College of Surgeons in Ireland. So our talk today basically explores why decades of neuroprotection trials in stroke have failed and why we believe that the future lies not in abandoning the concept, but basically in repositioning it. And in the thrombectomy era, neuroprotection must move to the side of reperfusion, where the tissue itself is still fragile, but salvageable. So, next slide. So here's the paradox. In many centers, thrombectomy restores flow in more than 80% of patients, and we know this from the Hermes collaboration published in The Lancet in 2016. However, when we look at the outcomes, only about half actually walk away with functional independence. So what I'm saying is we can open the artery, but have we truly rescued the brain? And I guess this talk is about why that gap persists and how neuroprotection, if it is actually delivered at the right time, could actually help in closing that gap. So the penumbra is actually the battleground. It is the tissue that is injured but is not yet dead. And after we open the artery, several things could go wrong at once. So capillaries could fail to conduct blood because of the swelling, the clots, and the pericyte constriction. The barrier between blood and the brain leaks, and this drives swelling and sometimes even bleeding. And inflammatory cascades actually accelerate injury as well. So Chamorro and colleagues writing in the Lancet Neurology in 2016 described these processes clearly. These processes being like excitotoxicity, oxidative stress, and inflammation. And unless we intervene in this window, viable cells are lost to the core. And this is precisely the target for neuroprotective strategies. So now we want to question why past neuroprotection failed. So given these mechanisms, one answer is timing. So most drugs that were given while the artery was still blocked, so they never actually reached the tissue at risk. Another mechanism being selection. So patients with little salvageable tissue were still recruited. So the endpoints depended on a single scale at 90 days, which is far too crude to detect early biological benefit. And animal models lack the actual complexity of human stroke itself. The Escape Anyone trial published in The Lancet in 2020 is a striking example of this. So neranotide, which showed signal in some groups, it actually showed interactions with alteplase washed out the effect. So what if neuroprotection failed, not because the biology itself was wrong, but because we actually put it in the wrong place in the first instance? So now we have to reframe neuroprotection in going forward. So instead of a pill tested in isolation, it actually should be embedded in the thrombectomy workflow. So, for example, it needs to be given at the moment when flow is restored and the tissue is vulnerable. The route and the dose should be chosen to actually reach the penumbra. And we cannot measure success by disability scales alone. We must actually track biological markers as well as functional recovery. So the idea naturally becomes a bundle. Cytoprotective drugs to keep neurons and endothelium intact, agents to control swelling and prevent secondary bleeding, and where the catheter is already in place, intraarterial delivery can target the injured zone directly. And across all patients, tight control of blood pressure, glucose, and even temperature should be part of the protocol. And one glimpse of this concept in practice actually comes from the CHOICE trial in JMA in 2022, where intraarterial alteplase was given after successful thrombectomy. So it actually showed that embedding neuroprotection in the procedure itself is feasible. So neuroprotection is not one pill, but it should be a coordinated package around reperfusion.
So now moving on, we have to acknowledge that in scenarios like this, selection is key. We should not include every patient with a stroke, but instead, we should choose based on tissue profile. If perfusion imaging shows a small core with a large penumbra, that patient has something to save. If the core is already dominant, protection is unlikely to help. Even without perfusion, a clinical deficit larger than the visible core suggests hidden penumbra. In short, the focus should be on biology, not simply on the clock. So, in terms of the routes and timing of delivery, how we deliver the treatment matters just as much as what we deliver. Intraarterial infusion during thrombectomy is attractive because the catheter is already in place and the drug can reach the threatened tissue directly. But not every patient will be suitable. So, Intravenous dosing immediately after reperfusion is a practical and widely available option. The key is not to keep the drug running for days. The injury is most intense in the first few hours after reperfusion, so a short exposure may be enough to make the difference. In terms of endpoints, our outcome measures need to evolve. Infarct growth on early imaging tells us that if tissue specific to this area is preserved or not. Edema and hemorrhage are also complications that matter to patients and highly reflect barrier integrity. Blood biomarkers like neurofilament light chain can provide a quantitative measure of neuronal injury. However, we still measure function at 90 days, but we should not rely on it alone. A trial which collects both biological and clinical endpoints gives us a much clearer picture of whether neuroprotection is working. In terms of delving into the trial design, we have to ensure that it fits the way that stroke care is actually delivered. Randomization should take place within the thrombectomy pathway so that treatment does not cause delay. Key variables such as whether the patient received alteplase, their collateral status, or the clot's features should be built into the design because they all affect outcome. Adaptive platforms can help by moving resources away from ineffective agents and towards those showing early signs of benefit. This way, we learn faster and patients are not left in low-value arms for years. So the next steps. Our lesson, or the general main lesson, is not that neuroprotection is impossible, but that we must be more deliberate. Firstly, preclinical work needs to be stronger and closer to the clinical reality, so only robust candidates reach trials. Tymiansky described this clearly. Translation fails when we move too fast with weak foundations. Secondly, early studies should be small perithrombectomy pilots that show the drug is hitting the target at the right tissue at the right time. Finally, strategies that show promise can then be scaled through registry-linked or adaptive platform trials so we can efficiently manage and learn while staying embedded in the real-world care. So, our closing message. It's truly and genuinely simple. Reperfusion gives us back flow, but too often the tissue is lost anyway. If we deliver neuroprotection at the site of thrombectomy in a protocol designed for that critical window, we have the chance to preserve more brain. The future is not a standalone drug. It is a protocol embedded in the act of reperfusion itself. Thank you all so much for your time and attention and the opportunity for both of us to present at this medical conference. We appreciate it a lot. And if anybody has any questions or insights, you're free to email both of us. Thank you so much.
Thank you.
Thank you so much, Mr. Andre and Mr. Naren. I would like to welcome next to our virtual stage, Dr. Emma, Dr. Lanya, and Dr. Maram.
Hello, can you hear me?
Yeah.
Okay, awesome, awesome. Can I start?
Of course.
Okay, so hello everyone. Welcome to the second annual Medical Student Symposium. My name is Dr. Emma Arifagic, and together with my colleagues, Dr. Maram Gad and Dr. Lanya Faik, we will be presenting our case report, which took us around 2 years to publish. Its title is, Was an Aortic Valve Replacement with a Mechanical Valve the Right Option All Along? Cogan's syndrome with recurrent aortic regurgitation, a case of evolving surgical decisions. So as I said, this is a published paper, so I do invite you all to read it, and we will be very happy to answer any of your questions at the end of the presentation. All right, so just a quick table of contents of what we will cover in today's presentation. So we will talk about what Cogan's is and its manifestations. We will briefly touch on our patient and also about two very important procedures called the Ross procedure and the mechanical Bentel procedure. And then at the very end, we're going to have a short discussion. All right, so first of all, what is Cogan's syndrome? So it's important to mention that there are only 250 documented cases worldwide of this syndrome. And ours was actually the only one documented in the Republic of Cyprus so far. So back to what it is. Cogan's is an autoimmune multisystemic disease. It's marked by intraocular inflammation, vestibulo-auditory dysfunction, and interstitial keratitis. So how does it present? Its main pathomechanism is through systemic vasculitis, which affects medium and large vessels. Alongside, we have aortitis, which can sometimes lead to cusp degeneration, prolapse, aortic insufficiency, and AR. Now, what I want you to understand is that the patient did not receive her diagnosis overnight. It took the patient years of going in and out of hospitals, in and out of the ER, trying to understand what was wrong. So I want to take you back to 2016. The patient came in with a runny nose, which lasted for weeks, and then suddenly it turned into severe vertigo and vomiting. And then when she was admitted, her CRP was super high. It was more than 100. And then she got discharged, she came back, and then in 2016, a month later, she was finally diagnosed with Cogan's syndrome based on the hallmark symptoms, including sensorineural hearing loss, bilateral uveitis, and keratitis. Now, fast forward to 2017, her symptoms worsened. So her hearing loss was bilateral, it was worse than before, and she needed to get hearing aids implanted. So far, what do we know about our patient? We know that she's very young, she's 23, she's a female, and she was diagnosed with Cogan's syndrome in 2016. Now, fast forward to March 2019, she comes back to the ER and she complains of mild fatigue and dyspnea. So at the ER, they did a TTE, and this revealed that she had mild to moderate aortic valve regurgitation, which they concluded was caused by her Cogan's syndrome. Now, in July 2019, this is when things kind of worsened. So she returned back to the ER, and here she complained of sudden severe onset of dyspnea, fatigue, and orthopnea. Now, this time the TTE was redone, and it revealed that she had severe AR with a preserved left ventricular ejection fraction of 60 to 65% and normal dimensions. Now, I remind you, she's a 23-year-old. This is usually not seen. So because of the severity of the case, she was flown from Nicosia to Germany. And in Germany, they did a couple of procedures, which my colleague, Dr. Maram Gad, will be discussing with you.
All right, so in this patient's case, an urgent surgical intervention was required. However, she expressed a strong wish to have children in the future. As we can see in the next slide, normally a mechanical valve replacement would be the preferred choice for someone of her age, but it was excluded because of the inherent thrombogenicity of the mechanical processes. During pregnancy, the body is already in a hypercoagulable state, which greatly increases the risk of the thrombotic state. So therefore, a safer, more pregnancy compatible option was needed. And that's when the next slide comes in. The Ross procedure was chosen as the ideal alternative in this case. This procedure uses the patient's own pulmonary valve to replace the disease aortic valve, and then the donor valve is then placed in the pulmonary position. This approach provides an excellent hemodynamic results, and it avoids the need for a lifelong anticoagulation, making it a safer and more suitable option during pregnancy. In the next slide, we will take a look at the first operation, which took place in July 2019. So intraoperatively, the aortic valve was found to be completely degenerated and with only the left coronary cusp intact. And there was even evidence of both acute and chronic inflammation. The valve culture tested positive for staph epidermis, and it confirmed the acute bacterial endocarditis. So the patient was then on 4 weeks of antibiotics, and she recovered really well. And then after surgery, she was actually able to deliver a healthy child and remained asymptomatic on intermittent tocilizumab. So the next slide takes place several years later, in early 2023. The patient did present again with severe fatigue and shortness of breath, similar to her first episode. She had no fever or recent infection, but the examination revealed a diastolic murmur, and imaging confirmed recurrent severe aortic regurgitation due to likely a tear in the right coronary cusp with a secondary moderate mitral regurgitation. The next slide, we'll take a look on her second operation. So given the recurrence of the symptoms and her decision not to have any more children, a mechanical ventral procedure was performed in September 2023. A large cusp tear and inflammatory changes were found again, but cultures were negative for endocarditis. She recovered from it quickly and was discharged after 10 days. She maintained stable INR levels on warfarin, and then she resumed on her cortisone and tocilizumab with uneventful follow-ups. And now my colleague Lania will take over.
Hi, I hope you can all hear and see me. Thank you, Moron. So this brings us to the end of our case report and the discussion. So this case report teaches us quite a few valuable things about Cogan syndrome. As Emma told you previously, it is so rare. There are only 250 documented cases, so the more information we can find, the better we can treat future patients. And one of the key things about Cogan syndrome is, as Emma said, it mainly affects the eyes and the ears and the cardiovascular system. But when it affects the cardiovascular system, it can be very brutal. It can progress rapidly. And from our case, our patient had aortic regurgitation, but then it progressed very quickly over just a few months into severe fulminant aortic regurgitation. And this is seen across the literature. There are many patients with Cogan syndrome that have cardiac manifestations that are in a much more severe critical state. So the point I want to reiterate is that if you have a patient with an autoimmune illness like Cogan syndrome, it is important to monitor their symptoms carefully. If they present with cardiac manifestations like dyspnea, syncope, palpitations, fatigue, it is important to follow it up immediately. This isn't something that you can leave for 2 weeks and review later if they get better. So it is important to promptly identify and investigate their symptoms because, as we now know, Cogan syndrome can cause quite severe cardiac manifestations. The second important point about something like Cogan syndrome is that, as my colleague Maram mentioned, the optimal treatment for an aortic valve replacement is a mechanical valve. We know that from general literature, it is longer lasting than a biological valve and optimal for a patient of her age. But because our patient wanted to have children, we were not allowed, or the doctors doing the surgery were not allowed to continue with a mechanical valve so she could have children in the future, because a mechanical valve requires lifelong warfarin therapy. But if you swap to something like heparin, it doesn't provide the proper anticoagulant coverage for a very hypercoagulable state that pregnancy puts you in. So our patient was given a Ross procedure and a biological valve as well. and it didn't work. It only lasted a little bit before her symptoms came back. And when they biopsied the new aortic tissue, it was completely obliterated. The inflammation completely destroyed the new tissue. Now, I wanted to mention this because when we were investigating the literature, we actually found a similar case of a patient with similar demographics. There was a 19-year-old patient documented by Paolini et al. That also had Cogan syndrome and aortic regurgitation, and she also wanted to have children. So they actually replaced her damaged valve with a biological valve, and she was fine. She lived on and had no more symptoms. In our case, the patient relapsed and had recurrence of her aortic regurgitation. So biological valve was suboptimal. So that is important to remember that in cases like an autoimmune disease, in general, it is important to note that a mechanical valve is better, but specifically when you have a patient with an autoimmune condition that gives you severe vasculitis like Cogan's, a biological valve is even riskier. The last point I want to reiterate is how important it is to be super individualistic with patients that have autoimmune diseases, especially something as rare as Cogan syndrome. There are so many other comorbidities, symptoms that the patient is dealing with, but you also have to take into account the patient's wishes. In our case, the patient wanted children, and it wouldn't have been fair to give her a mechanical valve and push that dream to the side. So in cases like Cogan syndrome, you need to adopt a super individualized, multidisciplinary approach. And the key takeaway from our case is if you have a patient with Cogan syndrome that has aortic regurgitation and an aortic valve replacement and is non-pregnant, I think I said that, but the most important or the most optimal solution is a mechanical valve. And we are open to any questions. We hope you found this case as interesting as we did. And thank you for listening to us.
Thank you very much for giving us the chance to present our work. And I hope you enjoy the rest of the symposium.
Thank you so much, doctors. It was a privilege. Thank you. So we would like to welcome to our virtual stage our final presentation, Miss Emilia Janiak.
Hello, can everybody hear me?
Yeah.
Okay, great. So good evening, everyone. My name is Emily Janiak, and I'm a medical student at the Royal College of Surgeons in Ireland. And today I'll be sharing insights from my ongoing review conducted in collaboration with researchers from the MD Anderson Cancer Center. And that will be focused on tumor-educated platelets as tools for ovarian cancer detection and monitoring. And this project builds on a growing body of research that's showing that how platelets that are often seen simply as blood clotting cells actually can carry an important information about cancer biology. So let's begin by understanding the scale of the problem. Okay, so ovarian cancer remains one of the deadliest gynecological malignancies worldwide, and each year we see around 324,000 new cases and over 206,000 deaths globally. And what makes this cancer so devastating is the late stage of diagnosis. About 70% of women are only diagnosed at stage 3 or 4, and at these stages, the 5-year survival rate drops to just 17%. Early symptoms like bloating or abdominal discomfort are subtle, and thus they're easily mistaken for benign issues, which then delays the detection. And this is why we urgently need more effective non-invasive tools for early diagnosis. In terms of the current tools, those diagnostic options are limited. Imaging methods like CT or ultrasound cannot reliably distinguish between benign and malignant ovarian lesions. Tissue biopsy, although it is definitive, it is invasive and doesn't always capture tumor heterogeneity. And our main blood-based biomarker, CA125, lacks specificity. It can be elevated in various conditions like endometriosis, menstruation, and pregnancy. And this diagnostic uncertainty leads to repeated chemotherapy cycles, unnecessary procedures, and often significant emotional and also fertility-related consequences for patients. So to close this diagnostic gap, we need markers that will be accurate, minimally invasive, and dynamic. And that's where liquid biopsy comes in. So liquid biopsy refers to analyzing blood or other body fluids in order to detect tumor-derived material. It's a rapidly evolving field that looks at circulating tumor DNA, RNA, cells, and extracellular vesicles. And more recently, also tumor-educated platelets, or TEPs. TEPs are platelets that have been molecularly and functionally altered by cancer cells. Through the constant interaction with tumor environments, they absorb tumor-specific RNA, proteins, and even signaling molecules. And what's fascinating is that these platelet changes can reflect what's happening inside the tumor, even before it becomes clinically visible. One of the earliest clues that we can actually see comes from the quantitative changes. Studies show that thrombocytosis, or elevated platelet counts above 400,000 per microliter, correlate with advanced disease, recurrence, and reduced survival. In fact, elevated platelet levels can actually be detected months before symptoms appear, and then they can predict lower 5-year survival rates, 71% compared to 91% for patients with normal counts. Similarly, the platelet to lymphocyte ratio, or PLR, has emerged as a simple prognostic marker where higher ratios often indicate more aggressive disease. And these findings suggest that platelets aren't just bystanders, they're active participants and also measurable early indicators of tumor presence. Beyond counts, the molecular contents of platelets tell us an even richer story. Through RNA sequencing, we can distinguish cancer patients from healthy individuals with up to 96% accuracy, and specifically for ovarian cancer, around 80%. A diagnostic panel called TPOC, which analyzed 102 platelet RNAs, achieved an impressive AUC of 0.918 in identifying ovarian cancer. Importantly, when platelet RNA profiles are combined with CA-125, the sensitivity for early-stage detection increases dramatically. And this makes TEP transcriptomics a promising complement for current biomarkers. Platelets also undergo major proteomic changes when they're exposed to cancer. In ovarian cancer, they become enriched with pro-angiogenic and pro-metastatic proteins, molecules that support tumor growth and spread. And these protein shifts can be detected even in microtumors that are smaller than 1 cubic millimeter. In one study, platelet protein profiling achieved 83% sensitivity and 76% specificity in identifying early-stage ovarian cancer. So from an analytical perspective, the platelet proteome acts as a real-time mirror of the tumor behavior. And when we look even closer at the microscopic and ultrastructural level, we can also see remarkable changes. Using electron cryotomography, researchers have shown that circulating platelets in ovarian cancer can exhibit disorganized microtubules and damaged mitochondria compared to healthy controls. Advanced microscopy techniques also show nanoscale reorganization of surface proteins like B-selectin, which may influence platelet-tumor interactions. And these findings reveal that ovarian cancer doesn't just change what platelets contain, it changes their architecture and also function. Beyond diagnosis, platelets can also help us monitor how well patients respond to treatment. After chemotherapy, platelet normalization often indicates a good therapeutic response. On the other hand, persistent thrombocytosis is linked to poor outcomes. And studies show that if platelet counts drop by less than 25% post-therapy, patients tend to have shorter progression-free survival. Even more exciting, declines in tumor-derived RNA within platelets can reflect molecular response to therapy, sometimes earlier than imaging can detect it. So, TEPs could serve not just as diagnostic markers, but also real-time indicators of treatment success or resistance. As the field advances, the sheer complexity of the platelet data from RNA sequences to proteomics and morphology makes AI indispensable in this diagnosis and also monitoring. Machine learning can detect subtle, multidimensional patterns that the human eye or conventional statistics might miss. For example, models can integrate platelet counts, size distribution, RNA expression, receptor density, and protein abundance in order to classify samples as malignant or benign. And research deep learning algorithms that train on over 1,300 cancer and control samples can achieve 99% specificity and roughly 80% accuracy in distinguishing tumor-educated from normal platelets. And what's remarkable is that these models don't just rely on a simple biomarker. They interpret signatures across thousands of transcripts and proteins simultaneously, thus mimicking the tumor's molecular fingerprint in blood. Moreover, AI also allows for longitudinal monitoring. It can track how a patient's platelets profile changes during chemotherapy or remission, and thus can predict relapse before clinical symptoms appear. With further validation, AI-driven platelets analytics could evolve into a decision support tool that could help oncologists determine when to escalate therapy and when a patient is truly disease-free. Clinically, we're now seeing the science move beyond the laboratory. There are several ongoing trials that are evaluating platelet RNA and circulating tumor DNA as diagnostic and monitoring tools for ovarian cancer and other solid tumors. In addition, there are several efforts that are being made to develop advanced preoperative diagnostic algorithms, including platelet analysis. And what makes platelets so promising is their practicality. Blood sampling is simple, inexpensive, and repeatable, and that allows for real-time disease tracking. Imagine a future where an ovarian cancer survivor could monitor a recurrence for a routine blood test rather than repeated imaging or invasive biopsies. So in this case, the long-term goal is to integrate TEP assays with existing clinical frameworks like CA-125 levels, imaging results, and also clinical history in order to generate a comprehensive, personalized risk profile. And such an approach could redefine ovarian cancer care, making screening more accessible, precise, and patient-centered. So in summary, tumor-educated platelets offer a simple yet very powerful window into ovarian cancer biology. They reflect the tumor's molecular, structural, and functional state, allowing the detection and monitoring through routine blood sample. By integrating platelet RNA and protein profiles with existing tools like CA-125 or imaging, and also applying artificial intelligence to interpret complex data, we can move closer to a non-invasive and highly personalized approach to early cancer detection. Ultimately, this research brings us nearer to a future where a single drop of blood could reveal, track, and guide treatment for ovarian cancer, transforming how we diagnose and care for our patients. So thank you for your attention and for the privilege of being able to present today. If you have any questions at all, feel free to contact me via email. Thank you.
That concludes our oral presentation block 3. We will now move on to the closing remarks. So before I do the closing remarks, I swear to God, I'm gonna fall in love. This is like the 15th time. We have some a small award ceremony for our in-person oral presentations. So we're not doing an award ceremony for the open discussions because I presented, so it would be biased. So it's just gonna be for the in-person. And it is a tie, but the people aren't here, obviously, between Mr. Mark Polemidiotis and Miss Christina and Miss Donadel. So a round of applause. Okay. Now just to close our symposium, I wanted to say just the massive dichotomy between last year. Last year, I think we had, other than the presenters themselves, I think we had 5 audience members, and today we had 83 registrations. So that was a massive difference from last year, and I just want to thank all of our presenters online and in person, and our amazing organizing committee, Alex for being our IT support, myself for getting through this day, and yeah, that's it. Thank you so much, everyone.